Representative Ivey will bring his bill, House Bill 495. Drew, would you read that in first, please?
Mr. Chairman and members, House Bill number 495 provides relative to advanced practice registered nursing, repeals collaborative practice agreement requirements for advanced practice registered nurses, authorize advanced practice registered nurses to prescribe, order, furnish, and otherwise provide medications, therapies, referrals, and other healthcare items and services, provides relative to the authority of advanced practice registered nurses to distribute certain medications in public health clinics, authorizes advanced practice registered nurses to furnish signatures and other types of endorsements required of physicians in certain instances, provides relative to staff membership of psychiatric mental health nurse practitioners at facilities, requires psychiatric mental health nurse practitioners who issue certificates possess certain qualifications, provides for definitions, provides for related matters.
And I think there's a series of amendments as well, Drew, to read in, or do we?
Do you want to have the?
And went away.
Yeah,
would you like to read
one amendment? That'd be good to get that.
Okay, go ahead, please.
Okay. Mr. Chairman and members, the set of amendments is coded 1267. 1267 is the code in the top right-hand corner. This set of amendments has been distributed and is available online. It is a single amendment which will work on page 6 of the bill. Page 6, the amendment will delete lines 14 through 19, which is the subsection F of RS 37, section 930, and it will insert new amendments to that subsection F, which would leave the resulting law reading as follows. Notwithstanding any law to the contrary, a certified registered nurse anesthetist shall not be required to have prescriptive authority to provide anesthesia care, including the administration of medications, anesthetics, and ancillary services necessary for the delivery of care within his scope of practice under the direction and supervision of a physician or dentist who is licensed to practice under the laws of this state. This concludes the amendment.
Thank you. Representative Ivey, would you tell us about your bill?
Yes, thank you, Mr. Chairman. Members, I certainly appreciate your time today to discuss what I believe is one of the most important bills that we can bring this session. Having served in the legislature for going on my 10th year, the reason that I do what I do and put the energy that I do in my efforts is because there's a primary focus on people. People is the reason why I decided to serve, and people is what keeps me in the game. Because, as all of you know, it can be challenging at times. Access to care is reaching a critical mass in Louisiana, and if you look at national studies and surveys and trend analysis, the gap for access to care is only widening. And so that is what this bill is about. It is about access to care. When we fail to provide access to care to the people of our communities, particularly our rural communities and particularly our poor communities, what happens is that we are essentially we have our lives or their lives in our hands, and we're failing them. When people can't go to a doctor, when they can't get some of these early detection screenings in their communities, then they have that massive heart attack. They end up having to deal with other diseases that require long-term, more aggressive treatments. It increases the cost of care as well. But more importantly, people die every day. When I decided to bring this bill, and of course, it's people on this committee have been working on this issue much longer than I have. But fundamentally, what really made it the easiest decision for me was that this bill will absolutely save people's lives. It will save people's lives. That's what this is about. We serve different areas of the state. Some of us are blessed to have more access to care than others. And so that is what I want everyone to maintain a focus on. is that this is about putting access to care into areas of our state where it is not available. So, over a year ago, because of COVID, the governor issued an executive order that removed the collaborative practice agreement requirement, so we can, help fill the emergent level of healthcare needs, and so over a year later, it's worked. It's been demonstrated that the wheels don't fall off the bus, that patients can have the care that they need, and so I believe the time for this is now. There are many people, and of course, from the physician community, who have brought many concerns, and I'm sure y'all have heard from them at length. I will tell you, I've received a few calls, and ironically, I've only received 2 emails this year compared to last year when we didn't move the bill. But I'll never forget the one call that I did take last year from a physician in North Louisiana. He called my assistant using some very colorful language and expressing his thoughts about myself, and she asked if it would be okay if I called him back, and he said sure. Tell him to give me a call. So we talked. I asked him what his concerns were, and he went and elaborated on, well, they shouldn't have this because they should be super, and all of these different sorts of things. And after he got done speaking, I said, sir, you do realize none of that is required under current law. And so I think there's fundamentally a misunderstanding of what is a collaborative practice agreement. It's a contractual relationship between an advanced practice registered nurse and a physician. That's what it is. There are multiple dynamics with regard to other relationships. If you have a nurse who is at a hospital or a physician's clinic, they have an employee-employer relationship. And so regardless of a collaborative practice agreement that may exist, an employer can tell their employee, we don't want you to write prescriptions, or we don't want you to do things that may be within their scope. And of course, as an employee, unless you want to be fired, you will obviously, do what your employer, asks you to do. And so, but there are those nurse practitioners who want to venture out into the underserved areas of our state. And if they work in a clinic, open a clinic, to provide that care, they have to have a collaborator of a same collaborative practice agreement, but there's a fiscal impact to that. Many of these practitioners, they provide care to the poorest folks in our state, and many physicians, it's hard to find physicians with any capacity that accept Medicaid. And so the margins are so thin. Otherwise, obviously, that's part of the issue. The margins are thin, and when we add the cost of a collaborator to that, in some cases it makes it not possible. Besides the hurdle of actually trying to find a physician to enter into that type of collaborative agreement with, even for pay, the collaborative practice agreement effectively it requires the physician to be available for a phone call should the nurse practitioner have any questions. Now, we extend as citizens and patients to the medical community at large. We extend them our trust that they are going to operate within their scope of practice, within their training, and within their experience. Whether it's a surgeon, whether it's a physician, GP, you name it, or whether it's a nurse practitioner. I trust the people who have devoted their lives to take care of us. And I believe that some folks do not extend that trust to the nurse practitioner community to operate within their scope, within their education, and within their experience. When anyone in the medical community, they identify something of a concern that's outside of their scope of practice or their training or experience, they refer them to someone who they know can address those medical needs. Doctors do it every day. Nurse practitioners do it every day. And so it is not a necessary contract. Yeah, for all of the employee-employer relationships, the controls are there for all of those concerns. The oversights are there because they're working in a different environment. But when you take a nurse practitioner and you stick them in a rural community, I've been told that there's one parish with no doctors in it. And so we understand this brings challenges that most of us that don't live in those communities, and myself being one of them, can't really comprehend. That it might take 3 or 4 hours to drive to a doctor's office. But that's if you can even find a doctor who'll take your Medicaid insurance. And so these are challenges that I don't face because I've got good coverage and I've got living in the East Baton Rouge Parish, have a lot of access to care. And even with all of that access to care, it takes a couple weeks sometimes to get in to see a doctor. How many of us have used these after-hour clinics? I mean, all the time. Because how many times do you need to see someone after hours? And I respect our all of our medical professionals, especially our doctors, but there's no access when a lot of people are able to take off work and bring someone to the doctor. And so that's why these clinics, and of course I know they're staffed with a lot of nurse practitioners and physicians, but it's that type of accessibility that is really needed throughout our state. Again, in particular our rural communities and our poor communities. And there's a long history that I'm not going to get into. I'm going to pass that off to someone who knows a lot more detail about the history of this. But for those who are calling for oversight, for those who are calling for supervision and all these different things, several of these things used to be part of the requirement, but it's evolved because there's been an understanding that the trust that our nurse practitioners are properly trained and educated and have the experience to provide the care that is within their scope. And so with that, I'm going to pass it off for a more oral history of this, where we are today. Thank you.
Good morning. My name is Dr. Jennifer Wright. I'm the Chief Nursing Officer at the Louisiana State Board of Nursing, and I've been asked to provide a little bit of historical context. Thank you again for the opportunity to be of service as you make these important decisions. So I just wanted to give a little bit of historical context of where APRNs have come from and maybe just some broad strokes in terms of what are we talking about when we say APRN. APRN is Advanced Practice Registered Nurse, and what that represents are registered nurses with advanced education, licensure, and certification. And again, just for context, when we use the term APRN, it's a broad term, and it includes what we call 4 roles. So that's nurse practitioners, certified registered nurse anesthetists, as have already been mentioned, but also clinical nurse specialists and certified nurse midwives. For the purposes of most of the discussion, you'll hear certified nurse midwife, nurse practitioner. Each of those nurse practitioners are licensed in a population. So their education has included a field such as family, psychiatry, neonatal, peds, that kind of thing. So I just wanted to lay the foundation for some of the terms that you might hear through testimony and discussion, but mainly the history of how legislation has evolved in the Collaborative Practice Agreement. The Louisiana State Board of Nursing and State of Louisiana have recognized APRNs for over 40 years in the state. In 1995, an act was passed by the Louisiana legislature that provided for a committee on prescriptive authority, and this is where the collaborative practice agreement idea started in terms of looking at what APRNs can do and how they can prescribe. So this committee was made up of interested stakeholders, and included not just the Board of Nursing, but also the Louisiana State Board of Medical Examiners, the Louisiana Board of Pharmacy, the Louisiana State Medical Society, as well as the House Health and Welfare member, Secretary of LDH, and a Senate Health and Welfare member. So from the beginning, inception of the idea of collaborative practice agreements and prescriptive authority, all of these stakeholders came together to review this issue. Again, that was 1995. As time progressed and part of the legislation that was passed in 95, a demonstration project was implemented to evaluate the prescribing practices of APRNs in Louisiana. A study came out of that in 1996, and it was found that APRNs, that they mainly studied outcomes, and there was an agreement that APRNs had the appropriate pharmacological knowledge and compliance with clinical practice guidelines, and it was beneficial to patients. As time went on, that demonstration project continued, and there was, again, joint oversight, and there was another act in 1997 that allowed that demonstration project and prescriptive authority to continue. Again,
30 more seconds, please.
Through the collaboration with LSMS, LSBN, LSBME, to the point of 2003 when the Joint Administrative Committee was dissolved and the Louisiana legislature determined that LSBN had the sole responsibility for issuance and oversight of prescriptive authority of APRNs.
Thank you. We have a question, Representative Carter.
Hi there. How you doing, ma'am, this morning? And I promised Representative Ivey I wouldn't say much on this issue, but I do have a question. In a malpractice setting, are APRNs, do they belong to the Medical Malpractice Act?
I believe our executive director is here and has more details about the oversight and malpractice issues related to APRNs.
When she comes to the table, I just like to ask because I do a lot of medical malpractice, and I know that there's a doctor's standard of care, but are we going to develop now, if they're independent from the doctors, a new standard of care for an APRN that is separate from the standard of care that we've used for primary care doctors over the last 20 or 30 years? And that's my question. I'm not quite sure how all that's going to work if you all of a sudden become independent. Do you have to pay into the Medical Malpractice Act? You know, is there a different standard of care? Who's going to be the witnesses? Is it going to be doctors or is it going to be other APRNs? All of those issues, somebody, I guess, will come to the table and talk about.
Representative Ivey, I think there's someone here that can answer those questions, correct?
Yes,
so
sir.
if she would come up and identify herself, and Representative Carter maybe can have an answer for your questions.
All right.
I'm Dr. Karen Lyon. I'm the Chief Executive of the Louisiana State Board of Nursing. I'm also an APRN, Adult Clinical Nurse Specialist. Representative Carter, in answer to your question, absolutely. APRNs with prescriptive authority and who practice pay into the Patient Compensation Fund. I have been monitoring the reports that are sent to me by the National Practitioner Data Bank. As you know, all discipline of all practitioners goes to the National Practitioner Data Bank. And every time we get a report of a payout, either from the Patient Compensation Fund or from any insurer in the state of Louisiana, I send that forward to our compliance division. We institute a full investigation. The standards for APRNs are based on their role in practice and their practice authority. And so they are judged in a court of law. We receive the results of that. I'm not privy to all of the court proceedings. I'm privy to what the National Practitioner Data Bank reports to me and the payouts that are made on behalf of those. Oftentimes they're made without any judgment of a plea of guilt or innocence, but payouts are made.
Well, do you go through the same? It has to go through a medical review panel before you can file suit, and
Yes, sir.
all those steps have to be followed.
Yes, sir.
All right.
Same steps.
And the doctor, the APRN would be responsible, or their insurance, for the first 100,000, and then the medical compensation fund would be responsible for the second 400,000. Is it just like with a doctor?
I can't report on the specifics of the amounts that you're quoting. I can tell you that APRNs are held to the standard of their practice.
All right. So what you're saying is they'll be judged by other APRNs, not by general practitioners?
I did not say that. I said that like I said, if it goes to a court of law, but it does go through the review panel, and the review panel reports that I've received, oftentimes they're with the NPDB report, oftentimes there's no mention of the review panel. But the review panel reports that I have gotten have been comprised of physicians.
All right. So physicians would actually judge the standard of care and whether an APRN followed the standard of care or not?
I don't think that's a correct statement either. Again, I'm just going to go back and tell you that advanced practice registered nurses are judged by the standards of their care that they provide within their scope of practice.
I'm still a little hazy about all this because I know how it works with doctors, but I'm not sure how you're telling me it works with nurses as far as what standard of care. If I accuse a doctor of malpractice, then I've got to have another doctor come in and say, this is the standard of care, this is where they violated the standard of care. And what I'm trying to see is, with an APRN, does an APRN come in and say, this is the standard of care and they violated, or do you have doctors come in and say, this is the standard of care that a nurse should have done and didn't do it? You understand my question?
I understand your question. And in a former life, when I did a lot of malpractice testimony on behalf of both plaintiffs and defendants, when we went to court or had a case where an APRN was being alleged to have committed a violation of the Practice Act, APRNs were brought in to testify against those individuals or to determine what the standard of care was in any given situation.
I was just wondering, and this is my last question, because I promised Representative Ivey that I would not get into this too deep, but do you think there is a different standard of care between somebody who comes in and sees an APRN and somebody who comes in and sees a primary care physician for, say, the same type illness or injury?
I think there is a standard of care for physicians in all specialties. I think there is a standard of care based on our scope of practice for APRNs based on our role in population, and we are held to that standard of care. And the Board of Nursing is here to ensure the safety of the citizens of Louisiana by ensuring that our APRNs practice to that standard of care.
Is there a requirement that an APRN belong to the patient's compensation fund?
I'm going to refer you to the APRNs who may come up to testify, because I'm not practicing currently as an APRN in the state of Louisiana. I can't speak to that. I have been told that that if they're practicing as an APRN, they have to pay into the patient compensation fund.
All right, that was my question. If somebody has any different when they come up, I'd like them to let me know that if there is an ability to opt out or not. I don't know about doctors if they opt in or not, but I can opt out or not. But I was just wondering if an APRN could opt out or not. And again, I apologize to Representative Ivey because I told him I wouldn't ask any questions. But these questions hadn't really got to do. This is more along the lines of what kind of standard of care are we going to be looking at once the collaborative agreement is gone. I think before, if there was a collaborative agreement, you kind of got the doctor standing behind the nurse. But without a collaborative agreement, the nurse is more, I think, more on its own. Would you agree, Representative Ivey?
That's the thing. The doctors are not standing behind the nurses. That's the thing. If a nurse practitioner opens up a clinic in a rural community and they're by themselves, or maybe they've hired a few other nurse practitioners, they have a written piece of paper, a contract. You're an attorney, and for $3,000, $4,000 a month, the doctor will also sign that contract and be the quote collaborator. And in that contract, the doctor has to respond to phone calls. The thing is that it is completely up to the nurse practitioner to determine whether or not she needs to call the collaborator. The collaborators don't call the nurse practitioners. There used to be a requirement to review charts and things like that. They had that removed.
What I'm
And so
saying
my
though
point
is,
there is no one standing.
let me say this: as a plaintiff's attorney in a rural community, and it doesn't get more rural than where I live. If I've got that collaborating doctor, and that nurse practitioner commits what I think is malpractice, that collaborating doctor's on the suit too.
Except for they're not. And and number one, and number two, okay, the collaborating doctor, again, they're not a part of the clinic. It's simply they're a resource for the nurse practitioner, and having spoken to a few of them, quite often, you have to find a physician to sign or enter into one of these agreements for usually significant compensation, and quite often the nurse practitioners, those aren't the physicians they call when they have a question. And there may not be the physicians that they call, to make a referral from one.
Well, I promised you I would not have a philosophical
I
argument
think
with
you.
you.
Helped bring up a very good point that it is a misconception of what the current law requires in a collaborative practice agreement. It gives an impression collaborator, as if there's this oversight relationship. There is no oversight relationship that exists in the collaborative practice agreements.
Well, I apologize because I told you yesterday I wouldn't ask any.
Hey, I understand. Look, you do that. We're good.
But I do think there's just
I
some
understand
questions I wanted.
your desires to make sure there's parity between the physicians and nurse practitioners, operating with regard to liabilities, and
that's my question.
And I
Strictly
appreciate-
about
and
liabilities.
it's my understanding, and I think we'll get some other folks, nurse practitioners here, who can speak to more detail about that. But it's my understanding that parity does exist. So when they get back, I think that's a good point.
If the poor citizen from Louisiana can get the same thing from a nurse practitioner if he's committed malpractice upon as a doctor, it makes things a little more fair is what I'm saying.
Sure. And another point I want to make just from the conversation is that talking about, look, nurse practitioners practice within their scope. Physicians practice within their scope, which is extremely broad. And so I'll use an example. If you have a surgeon, general surgeon, and they decide, I'm going to operate on an eye, that's going to be outside of their experience, practice, all that, because of the specialty nature of it. And so if something goes wrong, obviously that's malpractice because they were kind of in an area that they shouldn't have been without additional training.
I agree.
And so the same things exist, though, with the nurse practitioner community, where they are trained. So when someone comes in with an eye issue, they're not going to say, lay down, I'll take care of that for you. Well, that's operating outside of their scope, where obviously liability clearly exists. They focus on operating.
And all I'm asking is
operating after a surgery.
And all I'm asking is, if they do that, are they required to have insurance? That's the question.
Yes,
that somebody
Yes.
was to the table.
Yes.
Yes, sir. And
right.
Representative Carter, I just want, in 2020, I received 13 reports from the National Practitioner Data Bank regarding malpractice allegations against APRNs. Only one of those had a report from the review panel that assessed negligence on the part of that APRN. The others all did payouts without any determination of guilt or violation. They just
Well, I'm not worried about much as payouts.
But you're
and all.
asking about if
I'm wondering who's ultimately liable. That's my question.
if an APRN is sued, the APRN is liable.
And it's y'all's impression they're required to have insurance if they're out there on their own.
Absolutely. If they're operating independent practice, absolutely.
That's my question.
Every business owner.
I guess I could have made that one question that would have solved all this other stuff we've been talking about.
There's coverage to protect, again, to protect the patient should, something not go right or someone operate outside their
That's my whole crux of this question.
Thank you.
Thank you.
Thank you, Representative. I will remind the audience that the people at the desk are the ones that's supposed to be speaking and answering questions. We don't need a a uniform course, and yes or no, I'll let them speak. Representative Presley, you have a question.
Yes.
Well,
On now.
now there you go.
There we go. Thank you. Dr. Wright, when you introduced yourself earlier, you said you were a doctor. Are you a medical doctor?
No, I have a doctorate in nursing practice.
Do you think it could be confusing to patients if a nurse practitioner that has a PhD in nursing introduces themselves as a doctor?
Well, we are required by statute to identify ourselves in terms of the patient care population that we serve. So just like other professions are able to utilize their credentials appropriately, we are required to identify ourselves as nurse practitioners.
Thank you. Are you aware of the BME, Board of Medical Examiners rule, which is entitled 46, Section 7915, subsection C, which provides in part any attempt to exploit the, I'm sorry, I'll read the whole thing. In structuring any compensation arrangement or other financial relationship with an APRN, a collaborating physician shall be mindful that a CPA, collaborative practice agreement, is not an option for an APRN, rather is a requirement of state law. Any attempt to exploit such requirement by way of compensation arrangements for performing no professional services, merely serving as a collaborating physician under a collaborative practice agreement, or for an amount that is not consistent with the FMV of the services provided to an APRN, shall, under a CPA, be viewed as unprofessional conduct.
I am aware of that rule.
Are you aware of any nurse practitioner that's utilized that and reported a doctor to the Board of Medical Examiners for not utilizing or not performing the requirements under a collaborative practice agreement?
We don't receive the complaints that LSBME receives, so no, I'm not aware of the complaints that they received.
Thank you.
I want to point out that if in an arrangement, let's say a collaborating practice agreement, the nurse practitioner and the physician enter into, and there was this understanding of access and availability and things like that, and then suddenly the physician becomes less available. Obviously, they can report the physician if this based on the BME. I do want to point out, and again, I'm not suggesting that it exists in any great scale, but I do want to point out the challenge that they're going to put themselves out of business and not be able to see their patients because of that arrangement.
Yeah, and I understand that, Representative.
It could be challenging if anyone is faced with that decision.
Well, and I think that certainly, Representative Ivey, I appreciate you coming to the table and having this conversation. I think my concern is, earlier today you stated that the only thing that nurse practitioners do and the doctors do with the nurse practitioner in the collaborative practice agreement is get a check. And I think that's a little bit disingenuous to what the relationship is supposed to be based on the Board of Medical Examiners rules.
I believe the point I was trying to make, if I didn't make it that clearly, was that the only thing contractually that is required is availability from the physician should the nurse practitioner have need to call them. That's based contractually what's required. And so to the extent, and I wasn't aware of that particular BME rule, but I mean, it would be a good question to find out what those expectations are from the BME as far as the value added from the physician. Is that defined? I don't know. And so if it's not, I mean, to my knowledge, based on just the contract, it's a availability for phone calls.
And certainly, I would agree with you that that's certainly we need to have availability for the phone calls and the expertise to be used by the medical doctor. Dr. Wright, what's the difference in training between a family medicine doctor, for example, and a APRN that has the master's degree? Because my understanding is there's two different versions. There's a master's degree program and there's a doctorate program. Is that correct?
Right. APRNs have a basic RN degree for which they obtain experience and clinical hours and that kind of thing.
And what are those hours?
I don't know for the individual. There are different programs. There's associate degree, there's bachelor's degree.
Okay.
And then they are required to have either a master's, a graduate level degree, either a master's or a doctorate degree.
And is there any? But you don't have any specifics on the requirements of what that program entails.
Again, it depends on the program, master's versus doctorate. Typically, the RN has hundreds of hours of experience in their RN program, as well as typically thousands of hours of experience in their practice as an RN. So they bring that to their graduate level education and have at a minimum of 500, and it depends on the program, could be another 1,000, 2,000.
A minimum of 500 clinical hours?
Right.
What is, so clinical hours, 40 hours a week? Would that be an approximate amount?
I wouldn't put it to a weekly. It's a conglomeration, but again, there's also the experience that they have and hours of practice in healthcare that they have prior to that as well.
Sure. But as far as the, certainly an RN has hours of college level courses, correct?
Right.
And then there's some sort of amount that you have to have in order to get into an APRN program. Is there anyone?
Mr. Chair, there's a lot of.
Are there people that can
folks
speak
here
directly
who-
to that?
Yes, a lot
Okay.
of testimony
Thank
that can help, I think, answer a lot of these questions.
Representative Presley, are you continuing?
Hold on just a second,
Okay.
Mr. Chairman.
You've got the floor.
I'll hold the rest of my questions for
Okay.
other witnesses. Thank you.
Chairman Stagney.
Thank you, Mr. President. Dr. Lyons, can you come back up as well? Wanted that. Well, let me address Mr. Carter, my attorney friend on the committee. He knows that to commit malpractice, you got to go below the standard of care within your profession, and you got to have causation. They have their own board, their own standard of care, and it's not like they woke up and started practicing yesterday. They have a long history, 4 decades of research that proves that what they do is effective. And they do it in a very efficient manner. So I take it that you haven't had the opportunity to bring a case against a nurse practitioner because they probably have done a pretty good job. And so I want to bring that to light a little bit. In 2016, so you regulate all the nurse practitioners in our state, regardless of where they practice, correct?
Yes, sir.
So in 2016, the VA did a federal rule taking away these business restricted contracts. Has there been an increase in complaints or increase in malpractice suits against MPs since that rule was lifted? I mean, did we have some onslaught of neglected patient care?
No, sir, and if I could review for you, in 2016, we took action against 10 total APRNs. In 2017, we took disciplinary action against 15 total APRNs out of our 7,000 plus. I would like to just reflect to the committee that doesn't represent 10% of our licensees. It doesn't represent 1% of our licensees. It represents 2,000th of 1% of our licensees. In 2018, we only took 9 actions against APRNs. In 2019, we took 19 actions. And in 2020, we took 15 actions against complaints up to 65, but many of those complaints come in with absolutely no evidence. They're anonymous. They're often from people who have interpersonal conflicts with their colleagues or from spouses. They're going through a bad family situation and it's a way to get back. So they don't even result in investigations because they're anonymous and they're made without any evidence whatsoever.
And your mission on the board is like that of other healthcare professions. You're out there protecting the public, the consumer of healthcare. Is that correct? You're not there protecting the MPs or APRNs.
That's right, Representative Stagney. Our mission is to protect Louisiana citizens by making sure that RNs and APRNs are safe and competent and expert practitioners. We take our mission very seriously, and I think we do an outstanding job of regulating APRNs and RNs.
So when you refer to yourself as a doctor and Dr. Wright refers to herself as a doctor, you're not holding yourself out as a medical doctor or a doctor of medicine, are you?
No, sir, I'm not.
And you got training up and above a registered nurse, up and above an APRN, correct?
That's correct. In my case, it was a PhD in executive administration. In Dr. Wright's case, it's a doctorate in nursing practice.
You know, psychologist, optometrist, I'm a doctor of chiropractic. Never held myself out to be an MD in any way. But the same arguments are used to restrict trade against those professions, against this profession, against my profession that's being said today and have been said in these hearings since I looked at it back in 2012. And education and patient safety is not a contentious issue. The record is clear. What is a contentious issue is a collaborative practice agreement that may restrict access to care to our citizens. And at the very least, if physicians are not reviewing these charts, then why do we have them? I mean, is it simply to take money from the MP? I mean, there's no requirement that you have to review a chart. There's no requirement that you have to look over the medications being prescribed. And I mean that as a compliment because you've been doing it for all these years. And the outcomes have been very good. Your malpractice claims are very low. So I hope we can focus on what we're talking about here, and that's the collaborative practice agreement and whether that's a restraint of trade or not. Thank you, Mr. Chairman.
Thank you, Representative Johnson.
Thank you, Chairman. First of all, Representative Ivey, let me thank you for bringing this very important bill because I represent a district which are 4 parishes: East Carroll, Madison, Tensau, Concordia, and a piece of Catahoula. It's a very, very underserved area. Without nurse practitioners, I don't know what we would do. And let me just add, would you agree that nurse practitioners have been practicing at least 1 year under the government's executive order? Would you agree?
Yes, sir.
And the pandemic was deemed as an emergency, correct?
Correct.
So they were allowed to practice because there was an emergency. Wouldn't you agree that there's always an emergency in poor and underserved communities?
I exactly agree. It's a crisis. It's actually a crisis, and I think so many people are unaware of the significance of the emergencies that exist in so many rural communities and poor communities who do not have access to health care.
And so the pandemic only highlighted how urgent this is, but again, this was always there before the pandemic even happened, correct?
Correct.
I know a lot of my colleagues discuss quality of care, and it's my understanding that a physician may go and get a deep, broad scope of practice, but a nurse practitioner have to pick one of 5 particular areas, right?
I believe they have to specialize.
4. So they have a certain area that they're, and that's their scope of practice. So they're not like a physician. So they practice under those direct, criteria regulations under that particular scope of practice. Let me say this. I like to use a small example when folks say quality care. I've received many phone calls from physicians and other organizations, and they said, Travis, Representative Johnson, folks are not receiving quality care under nurse practitioners. And so if I'm starving and I just need basic food and water, and someone come to tell me, hey, you need a quality steak. You don't need food and bread and water, you need a steak. Does that make any sense?
It makes perfect sense, and I think what you point out is perspective. And as a legislator, I believe it's one of the most important things that we have to seek. I think it is why the deliberative process is so important, because we all come from different backgrounds. We all serve different communities. And Louisiana is, I think, one of the most diverse states in the nation. North Louisiana is very different than South Louisiana, culturally and in many other ways, but we're still all Louisianians. And so perspective is very important. And so someone who's starving and sees something that, someone who's been, living healthy and shopping at the high-end grocery store for those healthy foods, one person may look at, some item of food as, terrible, and the other person sees, something that's going to save their life. And so I think that is a very important perspective that we understand. And one of the ways that I've thought of expressing this is, how do you describe the quality of care that's available to the communities throughout our state when there's no doctors there? So the quality of care, if we think about it, the physicians aren't there. And so we're concerned about quality of care, and so people are dying because there is no care available. And where if someone went in, I routinely go in to the after hours clinic, see nurse practitioner, do a strep test and just seasonal allergies, things like that. But they take your blood pressure, they check your vitals, and many other things. What if that was available throughout our communities, and all of a sudden they notice something was concerning, and they can refer them to a physician? So, I think you need to go get your heart checked out, or
That's correct. And we always look at the numbers and say Louisiana ranked last. And it's just a common saying, if you keep on doing the same thing, you get the same results, right?
Correct.
And there are 8 successful states that are doing this already. They removed the collaborative practice agreement, correct? And they're probably some of the top tier healthier states in the nation. Is that correct?
Yes.
And so I just thank you so much for looking out for areas like mine, Representative Ivey. Again, I can't thank you enough how important this bill is for the underserved people in my district and in the rural places and poor communities around Louisiana. Thank you so much.
Thank you. And I've got the study that's been ongoing for the physician shortage, and in the study they discuss how to fill that shortage. And as you can imagine, on the good list, we're usually not ranked toward the top, and on the bad ones, and we are. And so on this one, it shows that Louisiana is ranked 48th, and that we are, by 2030, they're projecting a shortage of 4,820 physicians by that time. And so right now, from a ratio perspective, it's based on 2017 numbers, we are 69 per 100,000 physicians short. And the projection for 2030 is that we will be 100 physicians short per 100,000. The gap is widening. What really bothers me, having been in this institution for so long, I think most of us in our personal lives and our businesses, we try to be proactive. We try to avoid the problems that we see coming. But this institution of government and the slow moving pace that it has, and I appreciate that it can be a challenge sometimes. But there's some times where we are directly responsible for failing to act when we see these crises coming. We're already in the crisis. And the studies are out there that it's only going to be worse in the future. And if we don't take action today, because so many people, it's always about kicking that can down the road. We know what happens when you kick the can down the road. We deal with the problems that were kicked down the road 20, 30 years ago, and we're dealing with them today. This is people's lives, literally. People will die if we do not provide some basic level of care throughout our state in these rural communities and these underserved poor communities. So that's why it is so critical. I'm passionate about this because it is literally people's lives that hang in the balance. Thank you.
Thank you, Chairman.
Thank you, Representative Johnson. Representative Miller.
Representative Johnson, in that analogy, I'm not sure who was the steak and who was the bread, but I'm a steak. All right, so just go ahead on record as saying that, okay? To Representative Carter's comment earlier about insurance and liability, I'm not sure about the patient compensation fund, but the way it seemed like he explained it, I think the maximum a citizen can sue a medical provider or a physician is maybe $500,000. Well, I can tell you, plus medical bills. Well, I can tell you that I don't think we are in the patient compensation fund, but we are required to show proof of insurance when you're getting credentialed. I currently have a policy of $1 million per occurrence. So my argument, the way it seemed as he explained it, was if I screw up, the citizen can get more money from my policy than if you go under the patient compensation fund. So I'm not an attorney. I wouldn't want to debate him back and forth with it, but I just wanted to give him that answer. And when you're getting credentialed as a nurse practitioner, you must show proof of insurance, proof of coverage. I would like to just really say today, all these education debates, we're currently doing the work. So when we're discussing how many hours you have versus how many hours a medical doctor have, we are already doing the work within the scope of the nurse practitioners today. This debate should try to stay focused on, do you continue to have to pay a medical collaborator to do business in the state of Louisiana? Every medical provider in the state collaborates daily. I don't think you can operate without collaborating. You have to call a cardiologist to refer your patient if your patient's having a heart issue. You refer to a GI doctor every day if your patient is having a stomach issue that you can't figure out, or if you just need to refer them to get a colonoscopy. So the debate is not to end collaboration, because you have to collaborate every day. The question is, do you continue to pay a collaborator that you potentially never call just to do business and care for the citizens of Louisiana? So I would just ask the members here to just remember what we're debating. I don't think we're debating education issues, because we are already, nurse practitioners are already allowed to practice within their scope. So let's try to remember what this debate is. That's it, Mr. Chairman. Thank you.
Thank you, Representative Miller. Representative Turner.
Mr. Chairman, at the appropriate time, I'd like to move favorably on this bill, but in saying that, there's also going to be a lot of talk between all the associations with leadership next week to where we can put this bill in a little better posture. And I think the author knows that, and the groups involved. I think I spent 4 hours when I should have been in committee yesterday talking to different groups about this. My phone is blowing up right now with a doctor texting me and nurse practitioners texting me to view their opinion, and I think we're very close to coming that works for something that works. And sometimes something that works doesn't make either side very happy, but I think we're very close to where there's still a protection in this bill you're authoring to get in the right posture.
Yeah, and I'm glad you mentioned that. I'd like to transition back to the amendment that was offered that we haven't adopted.
Thank you, Mr. Chairman.
I do want to point out that the only concern that was brought to my attention is taken care of in this amendment. And so again, I know there was some reached out to some of the physicians may have reached out to some of the co-authors, and we will be getting together between here and the floor. But we try to address the concern. Somebody was concerned that there was going to be an expansion of prescriptive authority. There's no expansion of prescriptive authority. There's no expansion of scope. None of that exists. And if anyone has said that, I question. If someone's being misleading, right, they either haven't read the bill, right, or they're just kind of making things up. So if you hear anything along the lines of expansion, or it doesn't exist. And so anyway, if at the appropriate time, if we could do the amendment, adopt the amendment.
We could, with one of the members, like to offer those amendments. Representative Turner will offer them up. We've read them in already.
Thank you, Mr. Chairman.
Yeah.
Any discussion or questions on the amendments? They're online if you need to look at them that way. If there are none, the amendments are adopted as read. And yes, I do. Representative Presley, you want another bite?
That's mine.
Oh, I'm sorry.
Yeah, it's fine.
Did you come on?
Yeah, it's on. Mine's on. Yeah, mine's on.
Representative Sellers, I'm sorry.
It's a quick question, because I feel like we're kind of pinning the nurse practitioners against the doctors, and I definitely didn't like the analogy of the steak because I like steak.
Yeah.
All right, and I believe my constituents deserve steak, so I don't know what you want to give your constituents. My guys deserve steak, and the citizens. But just a quick question: in order to become a nurse practitioner, do you have to have supervision by a doctor? To become a nurse practitioner, do you have to have supervision, or shadow a doctor to become it?
Or have had like that in their.
In order to become a nurse practitioner, or is it an NP? NP, right? You have to get supervision for a doctor. I'm asking. It's a question. Yeah. To become a nurse practitioner, you have to have supervision for a doctor.
You don't. Okay. You do clinicals with doctors,
Right.
but you can during your clinical preceptorships, you may be under the supervision of an advanced practice registered nurse, which is most commonly the case, but you will also be working with physicians who work in your same area, and they will be providing supervision of some of the practice that you provide.
Okay, that's what I was asking, because I didn't know. I didn't know if you had to be, go through your clinicals with a doctor or an advanced nurse practitioner. That was the question. I was curious.
And one of y'all can correct me if I'm wrong, and I'm stepping outside of my experience here, practicality, but medical services are provided at physicians' clinics and hospitals, and and after-hour clinics, and so the majority of all experience in the nursing profession is in and around working with physicians. Is that a true statement? I can't ask a question, but one of you experienced people. I mean.
I don't even know your question.
Okay, never mind. Yeah. Anyway, the point is, look, the nurses work with doctors all the time. We've all been to the doctor. We know who's doing what. So anyway.
And Representative, you can't ask us questions.
Yes, it was rhetorical. Thank you.
No rhetorical either.
Chairman Bagley, if I could, I'd like to provide an up-to-date statistic to one that Representative Johnson used just for the committee's.
Representative Ivey, are you okay with this?
Yes.
It's just he used the number of current states that have full practice authority for APRNs, and I think he cited 8 or 9. It's actually 23. 23 states in the country have full practice authority for their advanced practice RNs, and I believe that 8 or 9 of those are at the top of the list for providing the excellence in outcomes. Their patient care outcomes are at the top of the list of the 50 states.
All right, thank you. Representative Johnson, did you have another bite?
Sure, I was just going to reference. I'm not comparing steak and to the care. I'm just saying basic needs. When it comes to basic needs, I just want to put it on record. Not gonna
I'm getting in trouble with your constituents.
All right, we're
gonna have more witnesses.
Yeah. Let's see who's button. I don't have any buttons. Yes, I do. There, Dr. McMahon.
Yes, sir. Thank you, Mr. Chairman. Thank you all for being here today. And I think it would be amiss if we didn't recognize what all the providers have done over this last year for us in Louisiana. I mean, it's been a difficult year for all of y'all, and we appreciate everything you've done, and we appreciate what you're going to continue to do across the state. I had a couple of questions, and Representative Carter started in the liability line. Does anybody know the makeup of the medical review panel for a nurse practitioner?
I'm sure there's somebody in the audience who might know to provide testimony.
I'd like to know that. I know from a medical physician side, usually it's if it's special practice, orthopedic, there'll be those kind of doctors on the panel. I just wondered how that worked.
Would this? Why don't you take the seat over here, ma'am? Introduce yourself, what you do.
My name is Dr. Lisa Ivey. I'm a nurse practitioner with the student loan for the doctorate. Yes, I have served on medical review panels. And if a nurse practitioner is involved, there's usually a combination of folks who sit on that medical panel, depending on what the issue is. Like if it was, and I'll give you the example. For me, I have a background in physiatry. So that's inpatient rehab. So we had an issue. with an inpatient rehab stay. It was with a nurse practitioner. So they asked a nurse practitioner to represent as well as other physicians. So a medical review panel is not just one type of person. It can be many. And I mean, on this particular panel, there was not a physical therapist, but PTs are in rehabs all the time. So that could be on your medical review panel too. It just depends on what the issue is.
Is the makeup of panel 5 like it is for physicians?
I don't remember exactly how many
fine.
there was of us. I have to apologize for that. But it's usually a conglomerate of what is the necessity. You know, it can be nurse practitioners and physicians. I've never served on a panel that was only a nurse practitioner. It was always a mix.
Okay, thank you. You know, I guess one of the concerns I have, you know, I'm non-confrontational in most things, and this is a difficult vote for me to come to. But I've served on a rural hospital board for the last 20 years, and you know, I think if you look around this committee, where you're located and where you're from, kind of predicates the way you see things in this state to a certain extent. But you know, we're down to 3 physicians in our community, and they're collaborating with about 3 nurse practitioners apiece. And we just cannot get family practitioners to come and stay. We'll give them a guarantee for 2 years, and in 2 years they're gone. And we're just not graduating enough family practitioners. Now, there's the other side of that. If we go down the road we look like we're headed today, we probably may have less family practitioners even. So that's a concern too. But to deliver services that we need in the rural communities, the nurse practitioners are doing a great job in our area. We have no problems with collaboration. Our hospital actually is the who pays all of our doctors and our nurse practitioners. They work for the hospital, so it's kind of a different situation than a lot of people are dealing with. But I just wanted to say I appreciate everybody in here and what they do for us, and I hope we can move forward. I hope we can move out of this committee and just look for a better way to provide care to our rural communities and our metropolitan areas too. So thank y'all for being here.
Thank you for your comments.
Thank you, Representative Cox.
Thank you, Mr. Chairman. It is a pleasure that you. I see you brought the bill again, and we've been here many times, and I've been here, and I have a few doctors in my family, but mostly nurse practitioners, and they've been, they go through a rigorous process, and nurses spend more time with a patient than a doctor does. And and not that I have any, I'm excited about what all the doctors and the nurse practitioners are doing in this state, but we're short. The bottom line is that we're short. And I live in a rural area, and I understand the demand. I understand the issue and the problem. Much like Representative Johnson, who's, he lives up on the Delta. And my hat's off to you. I also know this, that you've been through one hell of a time this past year for doctors and for nurses and for nurse practitioners. And my hat's off to you, because you can only take so much loss. And I do think that I want us to continue and this go forward. But I do want us to all consider that nurses and doctors, after this is over with, there needs to be some place where you come together like we did in the military and realize that you can only watch so much death, so much horror, so much tragedy, so much, even watching a friend die who's providing care. And there needs to be something somewhere when are we talking about what we really need to do to fill this shortage? And I totally agree. But I also know that in order to keep the doctors and the nurses on the line, and what I mean by the line, during your services, we must look at taking care of you guys. And there needs to be somewhere where we come together, and I think I've heard some say that they're doing this. They're coming together and you're having somebody guide the conversation, but not somebody come in who has not been there, who doesn't know what you've been through. It has to be you guys come together and you talk about what you need. I mean, what happened. Share your experiences. And I feel driven to say that because, I know how it is. And I know in this path that we're going through to get to where we need to fill the gap for the most needy, which is the poor who live out in the country, who live far away from folks, who can't get a medical doctor to come to them. So, having said that, I'm glad to see you here doing this. But I want to make sure that everybody realizes you have to do something to maintain this victory that you've accomplished. I feel we're getting close to victory.
Well, I appreciate. Look, this is a solution. Okay, now this right here won't solve the whole problem.
No.
And so I do get frustrated at times. When in this legislative process where everybody wants to tell you that your solution isn't good enough, that come back again, and they don't bring solutions. Look, we need an all of the above approach to solve the healthcare crisis. That's again, the gap is only getting bigger, and so we do need to take an all of the above approach. But I don't recall that many solutions being presented.
Well, what I'm not talking about, what you're doing is the right solution to move to take care of who we need to take care of. But what I'm talking about is something that doctors and nurses have to implement among themselves to maintain their ability to serve.
Sure.
So that's what I'm talking about.
Yeah.
And I'm not adding on to what you're saying. I'm just saying I agree with what you're doing. I know we need it. But I want to make sure that we take care of all the doctors and nurses and nurse practitioners, because you don't know the days that they've had to cry and they've had to go off to a room somewhere, try to drag themselves back together. And that's what I'm talking about. And I'm not trying to say anything negative about my hat's off to you, and I'm with you in this aspect, so you ain't got to guess on that. Yeah. But you probably already knew that.
I know you served on the front lines in the military, and you know what? Our physicians and nurse practitioners, they serve on the front lines.
Absolutely.
And look, I've never been there. I can't imagine, and so I have a deep appreciation for what they do. The long hours, they're out there saving lives every single day. So we have a deep appreciation for the entire medical community. And I'm glad someone mentioned that this isn't a nurses versus doctors issue. It's about access to care.
That's
right. So
I
appreciate your point.
And this is access to care, but also making sure that we do something to maintain that access, because you can lose people because they don't have anybody to talk to. I'm so tough. You're not that tough. I'm telling you. I'm telling you what I know. So I just want to throw that in there, and some of you out there know exactly what I'm talking about, because you can only take so many times. This one thing can click you, and you got to go somewhere. So anyway, my hat's off to you, and I'm with you.
Thank you, Representative. We have a gentleman that says that he can give answers to questions. I'm not sure which. So if you will introduce yourself, we could not find your card, but reintroduce yourself, and we'll do that.
Certainly, Mr. Chairman.
Oh, you've got to turn on his mic.
Well, you better show me. You.
And the ladies will run off again.
Okay.
Go ahead.
Thank you, Mr. Chairman. Mr. Chairman, committee members, I'm Dr. Christopher Foray. I'm from Franklinton, Louisiana, in Washington Parish. But at this point, I've come to you to try to answer some of your questions as chairman of the Patient Compensation Fund Oversight Committee. It's not why I'm here today, but I will be happy to answer some of the questions and the things that I can recall. Representative Carter, collaborative physicians absolutely have liability. Doctor, 3 members to the patient compensation review panels, mixed, nurse practitioners and physicians. Representative Miller, you're right. You don't have to opt into the fund. You have to have personal coverage. If you choose not to opt into the fund, there is no limitation of liability. You got it, sir. Other questions for this? Yes, we pay settlements for collaborative physicians. Yes, collaboration should be collaboration and not supervision. I'll say that as a physician, not necessarily the chair. I'm also a rural physician. I'm a country physician. I'm a country doctor. That's where my heart is. That's what I've done for almost 24 years. And that's another topic we could discuss at another time in this session. Would you guys like to ask me any questions about the PCF?
Anybody have any questions for the doctor?
I do.
Representative Carter, go ahead.
If they opt out of the patient's compensation fund, then they no longer have the benefit of the medical review panel. Isn't that right?
That's correct. And there's no limitation on liability.
All right. Do you know what percentage opt out and which percentage belong to?
As far as a pure number, sir, I can't give you that. The vast majority of practitioners opt in because it makes sense. Now, some large groups or hospital units have decided they could try to go on their own with this, but the vast majority of people opt in because of the protections provided by the Med-Mal Act of 1974.
All right. And is it a requirement that they have a set dollar amount of insurance if they opt out?
There's not, but there's not. So we've seen situations where practitioners have become in very much compromised positions.
So what you're saying is a nurse practitioner may be out there practicing with no insurance?
Self-insured. Yes.
Self-insured is no insurance, right?
Yes, Representative. That's not something I think you or I would like to embark on.
My question then becomes, shouldn't that nurse practitioner who doesn't have a collaboration agreement and doesn't have insurance post some kind of warning to anybody who comes in there, look, I'm not insured, enter at your own risk,
With all due respect, sir, that's your jurisdiction. And so, that may be a potential legislation.
Doesn't that scare you somewhat, too, as a rural doctor?
Lots of things scare me. Yeah. But as a father, as a physician, as a landowner, the thought of being uninsured would be frightening.
All right. And they're saying, at least I understood them to say, that all nurse practitioners have to have insurance. You're saying that's not the case.
I don't think that's mandated by statute.
That's all
it's good business sense, but I don't think it's mandated by statute.
Again, the nurse practitioners are saying they don't want to pay a collaborative doctor. What's going to cost them more, insurance or a collaborative doctor, you think?
Sir, about this, my realm here is about the patient compensation fund.
But if they're not willing to pay a collaborative doctor, they may not be willing to pay insurance either. Isn't that right?
All
right.
Thank you, sir. Any other questions?
Any other questions? If not, we have some other people at the table. Thank you, Doctor.
Thanks, sir.
Are we transitioning to public or testimony yet? So I can.
We're going to transition to the ladies at the table if you'd like to, if they'd like to speak.
Yeah.
Who's first?
I will go first. My name is Peggy Gautreaux. Just a little background on me. My uncle was former Lieutenant Governor for Louisiana, Jimmy Fitzmaurice. My father was Norris Fitzmaurice, who served for Pan American Life Insurance and the LSU Board of Supervisors for 13 years. So I have a tremendous amount of respect for what you all do. I would not want to do it. And just a little bit of understanding based on their experiences. I have been a certified nurse midwife for 17 years. 7 years ago, I opened up a rural healthcare clinic in Robert, Louisiana. There was a tremendous need there, and there was nobody out there to care for them, so we opened one. There's been a lot of history so far, so I'm just going to kind of dive in and hit a couple high points maybe that we haven't said. So back in the day, in the rural communities, they couldn't get physicians to go to these areas. So nurse practitioners kind of bridged the gap. It was easier for them, or they were able to get them to go out there. And so they provided a tremendous role. That was many, many years ago, and time has evolved. Today, there are over 200 rural health cares in Louisiana that provide care to the most in need. Majority of these are owned independently by a nurse practitioner. But all of them, provider-based or independent, all of them primarily employ nurse practitioners as the primary care providers. These patients that we see, to say that they have a tremendous access to health care would be an understatement. I think we've hit on that, so I'm going to move past that because I think everybody knows. But have we been offered payment for patients that couldn't pay to give us a goat? Yes, I'm sure many other people have, or in trade or whatever they could do. So the people we care for are the poor, the uninsured, or the Medicaid population, and that's our passion, and we couldn't be happier doing it for them. So we talked a lot about a collaborative agreement, and I'm going to focus on that because that is what this bill is about. So this is the current collaborative agreement that prior to the last 13 months we were required to have. In everyday practice, these are our collaborating doctors. So a typical day at a clinic is we are the initial access to health care for them, where if we're not there, they will either have no health care, get very sick and die, or they will use the emergency room as their primary care because they have no other choice, and that increases the cost for the state tremendously. So a patient, we're their access to health care, and this is all over rural clinics in Louisiana. We see them, we take care of them. When they exceed a scope, when they need additional care by a specialty physician or practice, we have over 60 doctors that we collaborate with that we can send our patients to for that care, but we don't have to pay them any additional dollars. We co-care together for these patients. I pulled up the definition of collaborate, which I thought was kind of interesting. And by definition, it's when two or more people or an organization come together to achieve a goal. And that's what we're doing every day, and in a true collaboration to care for the patients together. One other point I really want to hit home with, because I know my time will be up soon. So this has been debated for a really long time, and I'm sure we are very respectful to the many issues and concerns that you guys have all done a tremendous job over the years of debating, getting us where we are today. But for the last 13 months, this collaboration has been lifted. And it's a very unusual situation that we get to kind of try before you buy. So all the fears for the last 13 months, the state has been able to see that this lifting of this collaborative agreement to date has shown not one documented negative outcome because of the lifting in 13 months. And I ask you all please to consider this, because this really is the time to make this happen.
Thank you, Ms. Gautreaux. I'd like to ask you about the goat, but I won't.
We told him they could keep it.
Yes, ma'am, state your name, what you do.
Thank you, Mr. Chairman and members of the committee. My name is Denise Botcher. I'm State Director of AARP Louisiana. I'm also the co-lead for the Future of Nursing Louisiana Action Coalition, and I consider myself a nurse champion. AARP is a nonprofit, nonpartisan membership organization that champions issues important to the 50-plus and their families. We have a long history of supporting the state's nearly 700,000 family caregivers who help make it possible for their parents, their spouses, their children, their friends, their loved ones to live independently at home where they want to be. And that's why we strongly support this legislation, which would modernize Louisiana's nursing laws so that patients have direct access right where they live to highly skilled clinicians who are working to the full extent of their education and their expertise. House Bill 495 would significantly improve older adults' access to high-quality, affordable health care in communities across our state by cutting through the red tape that prevents nurse practitioners and all advanced practice registered nurses from doing their jobs, simply doing their jobs. For the past year, nurse practitioners have been working tirelessly on the front lines to protect us and fight this pandemic. They've saved lives. And they've done it all without the outdated business model of having a collaborative practice agreement, which was temporarily removed in the declaration of a public health emergency. To effectively fight the pandemic in communities across our state, we have needed everyone working at the fullest education and training to save lives. Older adults who are more at risk of serious illness and death due to COVID-19 had direct access to APRN care in a variety of settings. So as we've heard, in medical clinics and offices and community health centers, and right at home. And now more than ever, we need nurse practitioners working to their fullest education training to help close the demand gap and prepare for the future. The demand for care far exceeds the number of high-quality providers that we have today to even meet this need. In just 14 years, the year 2035, the United States will be at a major demographic shift and turning point. The elderly population will outnumber children for the first time in this country's history. Our aging population will increase the demand for health care as they manage chronic conditions like diabetes, high blood pressure, and Alzheimer's. APRNs working to the full extent of their education and training can increase their access to care.
You just want to speak, okay.
Decades of research will show you that APRNs provide high-quality care that produce patient outcomes comparable to those achieved by physicians, often at a lower cost and with higher patient satisfaction. So on behalf of AARP's 450,000 members and 677,000 family caregivers, I ask you to support House Bill 495 and allow APRNs to do their jobs, help fill the gap created by the state's physician shortage, and better equip communities across Louisiana for public health emergencies like COVID-19. Thank you.
Thank you. These are part of the people who have turned in cards previously and exercised a yes vote. We'll go through more of them. Have others. Eric Peterson, his president, would like to speak. Mr. Peterson, or where are you? And Dr. Sandra Brown, his president, would like to speak. Please introduce yourself. Tell us what you do.
Yeah. Good morning. Happy to be in front of this committee for the first time, though it will not be the last time this session. My name is Eric Peterson. I am the director of the Pelican Center for Technology and Innovation at the Pelican Institute. I'm in favor of HB 495 today. I would like to echo many of the arguments in favor of this legislation that we have talked about. I would like to point out that we recently wrote a telehealth paper examining many of the healthcare shortage in the state of Louisiana. I want to share a few facts with you. Louisiana has 26 physicians per 10,000 residents. That ranks right in the middle of the state. However, the parishes like St. Tammany, Orleans, Caddo have about 35 physicians per 10,000 residents. We have 15 parishes in this state with less than 5 physicians per 10,000 residents. I want to say that one more time. We have 15 parishes in the state with less than 5 physicians per 10,000 residents. This is not general or family physicians. This is physicians total. Many of the advanced practice nurse practitioners are very prevalent in these areas. I believe there's a map that sort of bears that out. But as important as healthcare access and outcome is to the state, we are here not to just talk about that issue, though I think it was paramount importance. Collaborative practice agreements are sort of a structure that is so strange that can only be created by government. We have people go to school for quite a period of time who are licensed by the state to practice, yet have to pay thousands of dollars for their ability to trade. If we put it in sort of another context, right, imagine that you went to school to be a tutor for math and you had to pay a teacher thousands of dollars to also teach the students. There's sort of a concept only so strange that could be created by government. I'm going to, again, we've talked about the 23 states. There's a long study by the Brookings Institute that looked at these 23 states that have gone away with their collaborative practice agreements. They've seen no increase in a decrease in quality of care. When we talk about access to care, right, we're talking a little bit about the steak or the bread. We're not having a debate whether or not you see a physician or a nurse practitioner. We're having a debate whether or not you're seeing a nurse practitioner or nobody at all. So I will end here and just say that we are in full support of this legislation. One of the great parts of the one of the silver linings of the COVID-19 pandemic is we got to see what regulations are needed and which ones are not via these emergency orders. I would just echo what we've seen, that over the past 13 months we have removed this regulation and we found it to be unnecessary, so we support its removal.
Thank you, sir. I'm sorry I did not see your light. Representative Hughes, you have a question.
Thank you, Mr. Chairman. And first of all, let me apologize to everyone in attendance about my tardiness. I know I missed a lot of the discussion. I had bills in multiple committees, and I'm still trying to figure out where I'm going to land on this vote. There's been a lot of misinformation via emails. I'm getting certain information from doctors, certain things from nurse practitioners, and so I just wanted to ask a couple questions on the record, and I think, Dr. Brown, you can probably walk me through that. The education to become a nurse practitioner. So I assume you have to get a bachelor's degree first, and then what? You become a registered nurse, and then what? How do you become a nurse practitioner?
Well, the pathway to becoming...
Excuse me, you need to identify yourself first.
I'm sorry. My name is Dr. Sandra Brown. I serve as the Dean of the College of Nursing and Allied Health at Southern University here in Baton Rouge. I'm also the co-chair of the Louisiana COVID-19 Health Equity Task Force, and I am a nurse practitioner.
Thank you.
To answer your question, Representative Hughes, the pathway to becoming a nurse practitioner is you obtain a bachelor's degree, which is a 4-year degree. Then you can proceed to obtaining a master's degree and continue on to obtain a doctor of nursing practice. All along the way, you receive didactic training and you receive clinical on-site training, supervised by nurse practitioners and physicians in your area of specialty. And I think we've already discussed the 4 areas of specialty.
Mm-hmm. Okay. And I'm assuming you have to take a certification exam to become a nurse practitioner or to become licensed?
Absolutely. All nurse practitioners take a certification exam. It's a national certification exam, which speaks to their level of competency to do the skills that they are prepared to do.
Is that a one-time thing, or do you every so many years do you have to recertify, or once you take the exam, are you done?
Once you become board certified, you are certified. Okay. There are requirements where you continue your continuing education requirements, CEUs, that are regulated by our Louisiana State Board of Nursing.
Okay, tell me about your continuing education. What are those requirements?
Those requirements are for prescriptive authority. You have to maintain a certain number of continuing education units specified in pharmacology so that you stay current.
On an annual basis?
Yes.
Okay.
Yes.
All right. And, you know, the speaker before you, I wanted to ask her, but either one of you can speak to this. I think collaboration is a really good thing. I have to do it on a daily basis at this Capitol. I understand that the collaborative practice agreements have been suspended for a year, and you know that's a test run. But what's the argument to eliminate them completely? I mean, why isn't collaboration a good thing?
Collaboration is absolutely a wonderful thing. Government mandated collaboration, where you're paying thousands of dollars for that ability to collaborate, whether or not you feel like you need to collaborate with that person or not in secret agreements. Is sort of a different question, and why we believe they should be ended entirely is 23 states have eliminated these agreements, and we have found no lack of quality of care. In fact, quality of care has increased.
If we eliminated the fee or capped the fee, would that be better?
If I could interject on that as well, it was previously testified by the lady who opened the clinic, and Robert. They collaborate every day. And so collaboration is good, and it's really necessary within the medical community, and it's just a part of that process. But the requirement to find a physician, particularly when you are want to have that independent practice, open that clinic, when you have to do that, it's a different type of relationship. You have to find a physician who's willing to enter into that contract, almost always for compensation. And it is in that requirement to enter in that binding contract and for compensation that makes it difficult. Some people have difficulties finding a physician to enter into a collaborative practice agreement. I've heard stories, and maybe there are some folks here who can testify on this personally, but stories I've been told where the collaborative physician died, and someone's operating a clinic, and they have patients that they can no longer see because there's no collaborating physician, because the law requires that. And so there's all types of things that do occur, and so this requirement is an impediment to truly expand access to care throughout our state. And so, again, it's a supply-demand issue. If there's, it's a difficult thing to find physicians to enter into some of these contracts sometimes. And then, and also when you're dealing with, again, as previously testified, when you're dealing with nurse practitioners who are trying to serve the poor communities, Medicaid, the margins are pretty thin. Which is why I think in physician offices they're just not necessarily able to afford to see those patients. When you add, just as a purely business owner, administrative, a doctor has their overhead costs in their clinic and their offices, and nurse practitioners have their overhead costs. They have insurance costs, and so when you add a $30,000 to $40,000 fee or cost to that, I mean, this could literally put people out of the market for being able to provide those services, just especially if they're trying to provide those services to the poorest of our community. So that, I believe, is one of the many reasons why it's essential that this requirement not be there. But to your point, collaboration happens every day, and it's a good thing.
I appreciate that, and I appreciate that there are 20-something states that have eliminated agreements, but that means there's maybe 30 states that still have them. Do other states have caps on the amount that can be charged, since we're talking about other states? Just out of curiosity. And if you don't know, it's no problem. Okay. Thank you, Mr. Chairman. I'll yield there. Continue to listen. Thank you.
Thank you, Mr. Hughes. Representative Presley has another question.
Thank you, Mr. Chairman. Representative Ivey, we've heard testimony today from several people regarding the collaborative practice agreement no longer being in effect for the past year. I'm looking at Louisiana Administrative Code, Section 46, or Title 46, Section 4513, which is the authorized practice agreement for nurse practitioners. And it provides, and this is from the State Board of Nursing's website, and it provides, in relevant part, Section 8A 1, in cases of declared emergency or disasters, as defined by Louisiana Health Emergency Powers Act, Louisiana Revised Statute 29, Section 760, ad sec, or as otherwise provided in Title 29 of the Revised Statutes of 1950, an APRN practicing with a previously approved collaborating physician at a new site, otherwise not previously reported to the board, may continue to practice during the time of the declared emergency, under the parameters of the signed collaborative practice agreement. So when we say that there was no collaborative practice agreement, in fact, the State Board of Nursing's rules provide that in declared emergencies, there's still a collaborative practice agreement. It's just that you can have it at a new location without, and the oversight continues under the prior agreement. Is that right?
Just to be clear, it appears that you're referencing promulgated rules and things that allow for a declared emergency, let's say like a hurricane. where if that happens. Now, under the governor's executive order, he suspended the requirement. That I think one is a provision to allow the continuation of practice during, let's say, a hurricane or something like that, where a physician may not be available.
If I may, it specifically says as defined by the Louisiana Health Emergencies powers, and it's the statute that the governor used in providing his authority. So I think that this is still applicable, and I'm not aware.
Has the ability to suspend provisions of the law that he believes create, that are, would be necessary to, deal with emergencies.
Correct, and I agree with that, and that's why I assume the State Board of Nursing put into the administrative code the exception, which is exactly what I read, as opposed to what the actual law is, and the exception only applies during that time of Louisiana Health Emergency Act. Am I incorrect on that?
Right. So if the governor would not suspend the requirement for, again, it's a big difference. And again, if somebody else can testify on the legalese of this, but just I'm a little familiar with the public health emergency statute.
And that's why I raised
the
question
can
to you.
suspend the law. That's a suspension. In Hurricane Laura, let's say a hurricane occurred. I'm not aware of the governor suspending laws in the past to not require this. However, the laws are also in place and rules have been promulgated so that in those states of emergency for a hurricane or whatnot, that they can continue in their providing health care.
Mm-hmm.
That exists now. What the governor did was suspend the requirement for collaborative practice agreement so that where states did not have they had excess capacity as far as healthcare providers, those folks could come down here and practice. That's what the governor did, and therefore, I think the governor's actions supersede the kind of safeguards.
Sure, and if someone else in the audience that's going to come speak has an answer that's more clear, more definite on that issue, I would like to hear that testimony. Thank you.
Thank you.
Thank you, Representative Carter.
I just wanted to. I heard the lady testify that all RNs have to have a 4-year bachelor's degree. That's not correct, is it?
The pathway to becoming a nurse practitioner, it starts with the 4-year Bachelor's of Science degree to get into.
I know of a shortcut that they use a lot, and that is if you go 1 year and become an LPN, then they go to Southwest Mississippi Junior College in Summit, Mississippi, and in another year they're an RN, so they can get to be an RN in 2 years or 2 years and a half. Isn't that correct?
Correct, but the question was, how do you become a nurse practitioner?
But that person still can become a nurse practitioner, even with that degree from college in Mississippi.
No, sir. You have to have a minimum requirement for admission into a nurse practitioner program. A master's degree program is the Bachelor's of Science in Nursing degree.
All right. So you're telling me that when you take this shortcut of going to Mississippi and get to be an RN in 2.5 years rather than a 4-year degree, those people aren't qualified to get to be nurse practitioners?
They don't meet the requirements for entry to become enrolled in a master's program. You have to have a BSN. You can get an RN, as you refer to, an associate degree, but then you have to keep going in order to get into the master's program.
Right. So there's an associate RN, and then there's a bachelor's RN.
Right. The Bachelor's of Science in Nursing is a 4-year collegiate degree at the college level.
All right. Because I was under the impression what you were saying is that all RNs had 4-year degrees, and I know that's not the case.
No.
There are some associate RNs.
Correct. But
All right.
The pathway to becoming a nurse practitioner is the 4-year degree.
All right. Can somebody who has an associate RN move up to take a nurse practitioner? Can they go to another college and do it, or to me, it's not been right that it's the same way in the medical technology field. In Louisiana, we have a 4-year college, medical technology degree. In Mississippi, they have a 2-year medical technology degree. And they say, when I come to Louisiana, I'm from Mississippi, I'm a medical technologist. But really, they haven't gone through the same training that a medical technologist in Louisiana has gone through. Isn't that right?
It's the Bachelor of Science degree that makes the difference. It's a
Yeah.
4-year degree.
But they do have 2-year RN degrees.
Correct, but they
Yeah.
do not have the Bachelor of Science.
All right. That's all. Thank you.
Thank you, Representative Carter. Representative Chairman Stagney.
Thank you, Mr. Chairman. I was struck by something you said, Mr. Eric Peterson, with the Pelican Institute.
Yes, sir.
Okay. The debate's really not between MDs and APRNs. The debate's on whether you're going to provide some care from APRNs or no care at all. And I think that has to be the focus of what we're talking about. 40% of our state is under Medicaid coverage.
That's
10% are uninsured. 15% are Medicare. MPs, more than 88% of them will treat those patients. They'll treat Medicare. More than 80 will treat Medicaid. Now, I have a large number of medical physician friends, and they don't treat Medicare and Medicaid because they don't pay enough. Medicaid, and I may be off on this, they may pay 85% of the Medicare fee schedule. So you're asking providers to go out into rural areas, treat patients, get pennies on the dollar, and then we're going to strap them with a requirement to say the only way you can go practice is you have to pay between $10,000 and $50,000 or $60,000 a year to a collaborator. And I don't even like the name of that agreement because I don't feel like that's what it is. There's no requirement for collaboration other than a signing agreement. And so I think it's a cost impediment to doing business if you're already getting pennies on the dollar and then you have to turn around and pay someone to do what you've been trained to do. I mean, is that your assessment? Tell me, dive into that statement a little more. APRN versus no health care.
Yeah, again, we had a telehealth study sort of dealing with this problem of access to care, which is where these numbers come from. And again, 15 rural parishes have less than 5 physicians per 10,000 residents. Again,
That's astounding.
I think that number's been provided to you. You can see it on a map. And overlaid with that is where we have nurse practitioners per 10,000 residents. In many of these parishes, it would double the amount of care available to people. I would also, you made a really good point about our state's Medicaid population. In the same study by the Brookings Institute, they found that APRNs decreased the billing to Medicaid by anywhere between 12 and 15%. Given that we've recently expanded Medicaid in the state, this is a large expense to the state. Not only can we increase the access to care, but we can save
greater savings.
We have greater savings. That's correct.
And throughout our state, under the current model that we practice under, have we had an increase or decrease in let's say, a health professional shortage areas? Has it gone up or down?
Again, we're a state with an aging population, as in most of the country. The access to care has only continued to decrease.
That's right.
In this state and actually as a nation for quite some time.
So almost our entire state is considered a medically underserved area, and we've gone from somewhere around 80% 10 years ago to 95% of a healthcare shortage area in our state.
And I can speak to that.
Please.
2020 is the year that changed the world. The coronavirus put health disparities in the spotlight, of which Louisiana cannot ignore. For more than a year now, nurse practitioners in Louisiana have been granted full practice authority through executive order. When Louisiana needed nurse practitioners, we stepped in and we stepped up to provide access to care to our citizens, many of whom are located in rural areas and health professional shortage areas where the demand for healthcare providers far exceed the supply. Along the Mississippi River, those parishes have one healthcare provider to serve 13,000 patients. Some of them have none. So with this legislation, we have an opportunity to advance and improve health care in our state, where we currently rank 50th. Last year, we were 49th. Second, Mississippi was last. Now, this year, our health rankings were 50th. We're at the bottom of the health rankings when it comes to cardiovascular disease, when it comes to obesity, when it comes to our overall mental distress. We're at the bottom. And these rankings are nothing new. Louisiana is sick, and it's been sick for decades.
And it's gotten worse because we don't have providers in areas
Absolutely.
to take care of those patients.
We rank 40th in the state for access to health care. And so if we keep doing things the same way, we're going to get what we've been getting.
And look, I commend over the last year, I think it's a shining example that the agreements may only impede the business model. But I go back to MPs have been doing this in the state of Louisiana, in the VA system for 5 years with good outcomes and low malpractice rates. So I think there's a long, tried and tested track record. And again, I'm going to refer back to 2012 when the Federal Trade Commission came out and said that these practices are nothing more than barriers to access to care for patients and barriers for competition among healthcare providers. And since that time, you've seen state after state after state lessen restrictions on MPs, and it's up to 31 that have lessened those restrictions. I appreciate your testimony. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Representative McMahon.
Is there a mechanism in place now if, say, a physician was providing a collaborative agreement to a nurse practitioner and for some reason they couldn't continue that process or, from a health reason or whatever, how does that work to get them back into practice? Is there a delay in getting the nurse practitioner back in the office?
Yes. The short answer is yes. If a physician currently cannot provide a collaborative practice agreement, or if they just choose one day, I'm closing my practice, or I'm retiring. We've had, and I'm sure you'll hear testimony of nurse practitioners that were given less than a 24-hour notice, and those patients who were under that nurse practitioner's care had no care. And so that is the detrimental outcome of having nurse practitioners tied to this piece of paper. It's archaic, it's outdated, and Louisiana has an opportunity to move that pendulum where we are now at 50th. We can no longer stay there. We need solutions, and this is one viable solution to providing access to our patients, our citizens, that we're called upon and obligated to serve.
Thank you for that. How long would it take to get that process back in place on average? Would you say if somebody come up one day and for some reason, whether it was health or death or whatever, did not have a collaborator, how long would they be without a collaborative?
There's a process that you have to go through. You have to submit paperwork to the State Board of Nursing. It has to be approved and regulated. So it's not just an overnight thing. It is a process to acquire another collaborative practice agreement with another physician.
Okay, thank you.
I'm sorry. Thank you, Dr. Mann. Caught me asleep. There are no more questions that I have, so we'll call other witnesses to the desk.
Thank you, Mr. Chairman.
I thank both of you for coming and speaking today. Terry Sterling with Nursing Leadership, and Kathy Baldridge from Louisiana Association of Nurse Practitioners.
You go first.
Please, ladies, please introduce yourself for the record and tell us where you are, where you go.
Thank you, and good morning, Mr. Chairman, and to the members of the committee. It is surely a pleasure to testify this morning, and we appreciate your time. As mentioned, my name is Terry Sterling. I'm a registered nurse, born, raised, educated, and practicing in Louisiana. I'm also a board member of the Louisiana Organization of Nurse Leaders and previously served as the Chief Operating Officer and Chief Nursing Officer for Our Lady of the Lake Regional Medical Center here in Baton Rouge. More importantly, I'm a founding member of Louisiana Action Coalition. Louisiana Action Coalition was created to advance the recommendations of the Institute of Medicine. Nurses across this country recently celebrated the 10th anniversary of the Future of Nursing Campaign for Action. This document was a blueprint for advancing the health of our country through the advancement of nursing, highly skilled and trusted healthcare professionals. This year again, nurses were voted the most ethical and trusted profession for an impressive 19 years in a row. The Future of Nursing Leading Change Advancing Health report was supported by Robert Wood Johnson in partnership with the National Institute of Medicine. It promoted 4 vital messages, but for time constraints, I'll just highlight one of them, the one we've talked about today. Nurses should practice to the full extent of their license and their training. You've heard today the important role that nurses played in the global COVID-19 pandemic. The pandemic revealed the incredible and often tragic inequities in our healthcare system. In response, yes, the governor issued the executive order, and 8 states also granted full practice authority, and 13 additional states reduced restrictions. This step fulfilled the Future of Nursing recommendation, allowing APRNs to practice to the full extent of their license. For a year now, as we've talked about, nurses have stepped up to close the gap in access to care through our state's urban and rural settings. We know that a relationship with a provider matters. It provides access and care because I trust my provider, and in many communities, the advanced practice nurse is that provider. Today, yes, 23 states, the District of Columbia, and 2 U.S. provinces grant full practice authority. These states represent 8 of the 10 healthiest states in America. With this legislation, we too have an opportunity to improve healthcare in Louisiana. This recommendation from the Future of Nursing is supported by the American Hospital Association, in addition to the Federal Trade Commission and many others. All of the commissions that were brought together to contemplate a better Louisiana through COVID also recommended full practice authority. The Resilient Louisiana Commission, the Louisiana COVID-19 Health Equity Task Force, and the Louisiana Economic Recovery Task Force. I ask for your support for this legislation that promotes full practice authority. Through this legislation, Louisiana has an opportunity to make meaningful change to improve the health outcomes of our citizens for decades to come, because certainly we believe that this pandemic will not be the last. The public's trust in nurses, including our advanced practice nurses, has been, for the last 19 years,
3 minutes.
Well placed and well earned. The time is now. Thank you, and I appreciate your time and ask for your support.
Thank you.
My name is Kathy Baldridge, and I am a family nurse practitioner. I am also the president of the Louisiana Association of Nurse Practitioners, and I'm representing the more than 5,000 NPs in the state. And I'd like to take the opportunity to thank all that's in the audience with a green sticker for taking time out of their day to come and be here in support of this. So thank you all. As you just heard, various national organizations, state gubernatorial, and legislatively appointed committees have made recommendations to allow nurse practitioners to advance to the full extent of their education and training. The key words there are their education and training. There is no amount of legislation that you can pass that will ever make me a physician. I am educated as a nurse practitioner, and I have to stay within my lane. So, one of the analogies I've used is a 5-lane highway. And I have to choose my lane of the highway to be educated in when I advance my degree. I chose to be a family nurse practitioner. That education requires that I stay within my lane. That is my scope of practice. I cannot move outside of that lane. The collaborative practice agreement is not what keeps me in that lane. It's my education, it's the State Board of Nursing, it's the regulations that are already in place that require that I stay within my lane. And there are safeguards in place that if I don't stay within my lane, that I am reprimanded for that. So those safeguards are already in place. At the executive order, you've heard about that. What I could do on March the 30th of 2020 did not change after March the 31st of 2020. The collaborative practice agreement was removed, but my scope of practice didn't change because that's dictated by the lane of the highway that I'm in. There are stories across the state that I've heard from various nurse practitioners, and there's one where a physician did walk in, physician collaborator, and resigned effective immediately. There are some rules in place that say that they're supposed to give us a 30-day notice for that. Sometimes that doesn't happen, and sometimes those are reported. But this one did and left. I think left the state entirely. And so, those nurse practitioners that were seeing patients in those clinics, without the removal of the collaborative practice agreement requirement through executive order, they closed the doors because while they have the ability to do what they do, they don't have the authority unless there's removal of the collaborative practice agreement. So with the executive order, that gave them the authority to continue practicing within what their ability is. We do collaborate. Collaboration is inherent to what we do. In 2012, we were here with the same ask to remove the regulatory red tape, and we talked about access to care. I wonder what 2020 would have looked like had that passed at that time. So I'm asking you to support House Bill 495.
Thank you very much. I have my light blinking. Representative Miller, is it yours?
Ms. Sterling, could you elaborate the Federal Trade Commission? You said that they support this bill. Do we know why?
It's related to unnecessary restraint of trade. I think your comment was very good. Nurse practitioners are doing what they do every day. This piece of paper is a business arrangement. It's not a clinical arrangement. You heard Kathy's testimony. What she did the day before the practice, the executive order was suspended, and what she did the next day. It's really around the Federal Trade Commission and others look across the nation at any policy that is anti-competitive. And that's why they support the removal of these practice barriers.
Thank you for your explanation. You also said the American Hospital Association supports removing collaborative barriers, correct?
Yes, the American Hospital Association, in cooperation with the American Organization of Nurse Leaders, all support this legislation.
Thank you.
Thank you, Representative Miller. Representative Presley.
Thank you. Mr. Speaker, or Mr. Chairman, thank you very much. What are the 4 practice areas of scope that are currently allowed by I think we heard testimony earlier. There's 4 areas that y'all are allowed to scope.
4 areas, right.
And what are those?
Nurse practitioners, there's CRNAs, certified nurse specialists, and certified nurse midwives. But within the nurse practitioner role, there are various roles that you can choose to be educated in as a family nurse practitioner, as a psych mental health nurse practitioner, women's health nurse practitioner. Those are some examples. That's the lane of the highway that you choose if you choose to become a nurse practitioner.
And I guess my question is, are there more than just those 3? The family medicine, psych, women's health. What are the other ones?
Adult gero, acute care, nurse practitioners, pediatrics, psychiatric mental health, neonatal intensive care.
And if the collaborative practice agreement was removed, let's take pediatrics. Everybody knows what a pediatrician does, and I've got kids as well. So I mean, we go and honestly, we're treated by nurse practitioners at times as well. So, but if this was removed, what would be the difference between going to a pediatrician's office and saying a nurse practitioner set up their own office? What would be the difference in that?
So, and they can establish their own office, and they can do that now.
Okay.
Even with a collaborative practice agreement, and we see that in our communities. The problem is that, so I think, are you asking about scope?
So I'm asking about the scope and the difference between the pediatrician and the nurse practitioner.
Right, we do
specialty.
have some similarities, but at the point that it's outside of our scope of practice, the condition is deteriorating of the patient, or there's something that doesn't fall within a guideline that we've been educated in, we refer them.
Sure, but I guess my question is, if this were removed, and you didn't have the opportunity necessarily to pick up the phone and say, "Hey, I guess my question is the pediatric nurse practitioner currently required to collaborate with a pediatrician?"
With a pediatrician, someone within the same specialty, but they are not required if their patient requires a pediatrician service. They don't have to refer to their collaborating. They can refer to a different pediatrician. So does that answer your question?
That does answer that question. Thank you. And the pediatrician, let's stay on that one. For a nurse practitioner to be a pediatrician specialist, is that or pediatric specialist?
Pediatric nurse practitioner.
What would that additional training? What would that training look like? We know we go through the RN to nurse practitioner. What's the training there?
They choose that lane of the highway. So they are only educated in pediatrics. They are not educated in women's health. They're not educated as an acute care nurse practitioner. They are educated solely in that lane of practice.
And what does that education look like?
I'm not a pediatric nurse practitioner.
Is there a pediatric nurse practitioner that's here today?
There are, I don't know.
That might be willing to come testify? Sure.
We'll need a card. We don't ask questions out of the audience, but you need a card. You're okay. You're.
Well, I thought they were looking for
Card.
a specialty.
Could she get a card? She's already had a card.
You have a card.
Go ahead. Yes.
So I am a neonatal nurse practitioner.
We need your name and what you do.
I'm sorry. My name is Jennifer Lemoyne. I am a neonatal nurse practitioner.
Thank you.
Specialty training for a neonatal nurse practitioner is very similar if you would go into the field of neonatology.
Okay.
Where speaking also to Representative Carter, I started out with an associate's degree, which is a 2-year degree from LSU Health Science Center. Then I went back and got an additional 2.5 years to earn my bachelor's in nursing. Then I returned to LSU Health Science Center and earned my Master of Science in Nursing. And at that time, I specialized. My lane is as a neonatal nurse practitioner. So my training, my area of specialty is in that realm. So the 1,000 clinical hours that I got at LSU Health Science Center specialize in neonatology. In addition to that, and I can speak to the pharmacology, having gone to LSU Health Science Center, we sat in the same pharmacology class as the med students. We took the same exams, we had the same instructors. So when I sit for a certification exam in my area of specialty, that is my scope, that is my training, that is my education.
And I guess, physicians, what's the physician called that does neonatal?
A neonatologist.
Neonatologist, great. So a neonatologist goes through 4 years of medical school, and then goes through a residency program in neonatology. That's 2-3 years.
No, actually, I believe a neonatologist is first trained as a pediatric.
Okay.
A pediatrician.
So that's a residency, correct?
Yes.
And so I think it's a 3-year program.
3 years.
So 3-year program,
and then they specialize. They do a fellowship. They do a fellowship in
neonatology.
neonatology.
And the fellowship is how long?
Okay, so, but let's not compare apples and oranges.
Anyway, excuse me, the audience is not up on the mic, and please be quiet. Sergeant at Arms, if you'll watch that for me, please. Thank you.
So, a neonatologist works in a hospital and is a specialist.
Okay.
As a neonatal nurse practitioner, I would work in a hospital.
Okay.
The rules and regulations of my scope and practice is not governed by the neonatologist. It's governed by the hospital.
Sure.
So having a collaborative practice agreement with the neonatologist does not change my scope of practice. I could not go and open my own clinic. I could not say I'm a family nurse practitioner and do primary care. That's not my scope.
So
of
as
practice.
a nurse practitioner, neonatologist, or neonatal nurse practitioner, I guess
Yes.
is the right way to say it. You would not be able to go and open in your own
No,
facility.
I would not. I would not. I have to stay in my lane. Just as a family nurse practitioner, and I also teach at a university that educates family nurse practitioners. They are trained in a certain area. So when we talk about massive number of hours, that physicians rotate as Dr. Dawson can attest
Sure.
to that. You know, they spend some time in family practice, they spend some time in orthopedics, but for nurse practitioners who are family practice, it's all of their training is in family
And I
practice.
understand that, but I mean, the spending some time is during medical school. It's during the 3rd and 4th year of medical school where you do a rotation in each thing, and then you do the residency. And in neonatology, you do a 3-year residency as a pediatrician, and then a 3-year residency as a neonatologist.
And I would
correct?
have done that if I wanted to be a physician.
Absolutely. So what I'm asking is, what's the difference between what you do and what a neonatologist does?
As far as the hospital setting, we have the same privileges. I am credentialed through the medical board at the hospital. I have the same privileges as a neonatologist, with the exception I cannot pronounce death and I cannot admit a patient. I have to admit under a neonatologist. I can prescribe. I can assess, I can order and interpret labs, I can do procedures such as a lumbar tap, I can insert central lines. All of those things I have been trained for, and I actually have competency-based education. You have to be able to perform those procedures so many times before you're able to do them. And I can tell you in a neonatal setting, the NNPs actually round on the patients and do the majority of the procedures. Neonatologists are there for consult if we need them. So are pediatricians in Well Baby. We go and see Well Baby patients who may need higher level of care to be transferred to the NICU.
Do you think that the additional training, and with due respect to my good friend, Representative Miller, I see this as there is an educational component in my eyes, and a safety side. And I guess what I'm asking is, do you think that the additional training for the 3 years pediatric residency and the 3 years of neonatology provides an additional education level that's needed for patient safety?
I don't think it provides an additional, when you say that's needed for patient care, because when I sit for that certification exam and when I am employed by that hospital, I am deemed safe to take care of those patients. A background check is done. I have certain standards that I have to meet. I have continuing education hours that I have to meet. So I would not be employed if I was considered unsafe.
Absolutely. And I mean, there certainly is a role in my eyes for nurse practitioners, and particularly the collaborative practice, I think makes, it seems to be working, particularly in a hospital setting, particularly in a setting in patient clinics where they're doctors.
Well, again, it's not the collaborative that binds me in the hospital.
Sure.
It's the credentialing through their medical board. I'm an employee of the hospital.
Sure.
I'm credentialed just like a neonatologist is.
Thank you.
Thank
all the
you,
questions I have
Representative
now. Thank you.
Presley. I remind the audience that this place runs on ritual, and there are certain procedures. All this is watched worldwide. You'll be surprised that the people said they saw you on television. And so there has to be maintained order. Everybody has to have a chance to say what they need to say. They should not have to fight someone else over it or speak over someone else. The members are trying to listen to some to make their decisions up. Some have already made. I understand how that works. But please cooperate here with us to make this thing run orderly. Thank you. Now, Representative Miller, you have a question. Just
another statement. Thank you, Ms. Lemoyne, for your very thorough answers and comments. And I would just like Representative Presley to hear a real life situation that's going on. So I've been talking to my local hospital, Opelousas General, and their CEO is trying to create a NICU, is trying to offer the services in Opelousas instead of having to transfer the newborns every time something's going. He cannot find a neonatologist. Either he can't afford it or one is not available. So one of his plans that he's actively working now is looking for an experienced neonatal nurse practitioner. And the reason he's trying to develop that is you either offer the services or you stay like you are now and you have no services. And so I think it's very important that the committee realize that we're not trying to compare our education to the neonatologist, but you're trained and within your scope, you can offer the services currently. And so I just wanted to make sure I went on record explaining that we're having these situations already with or without the collaboration. So we're not changing our scope. We're only asking, is the collaborative agreement that you have to pay for should be continued? Thank you.
Thank you, Representative Miller. Now we've got a couple other people that want to speak. Ladies, thank you.
Thank you.
Esther DeJong, I believe. LA affiliate. And Mark, what is that? LANP? Oh, okay. I apologize. Well, I'm going to let you straighten that up when you sit down. You can.
So my name is Esther DeYoung. I'm a certified nurse midwife from New Orleans, and I'm a member of the Maternal Child Health Coalition of New Orleans. And I want to briefly speak about the maternal and infant health implications of this bill we're considering. I think we're all aware that here in Louisiana, our infant and maternal mortality rates are among the highest of the nation. And one of the key factors that has been looked at is access to maternity care. Recently, researchers at Tulane, Dr. Wallace, and her team have identified 24 parishes in Louisiana that have no obstetric providers at all. No nurse midwives, no obstetricians. And they found that women who live in a parish, what they classified as a maternity care desert, are 3 times more likely to die from obstetric causes of death than women in parishes that have greater access to obstetric care. And even startling to them was, and even more significant, is that women in these maternity care deserts are 91% at increased risk of death during pregnancy and postpartum to all other causes. Car accidents, homicide, compared to women in parishes with greater access. So midwifery care has been documented in large body of research as improving maternal infant health outcomes, including maternal mortality, postpartum hemorrhage, risk of infections, perinatal, neonatal, and infant mortality rates. Research has also shown that eliminating the CPA requirement in a state increases the midwifery workforce in that state and improves birth outcomes. So removing the CPA requirement for APRNs is a no-cost intervention that can address our state's maternity care shortages and improve outcomes for birthing people and their infants in our state. Thank you.
Thank you. Introduce yourself, please.
Mark DeCluitt, psychiatric nurse practitioner,
Good morning, Mr. Chairman, members of the committee. Thanks for the time today. I'm here to kind of, I think, give a little bit of an illustration as to what the CPA is providing as it relates to a barrier to access. I'm going to tell you a brief story about Jack. He's one of the first patients I treated at a newer clinic we opened in Lafayette in May of last year. He came to our treatment center looking for treatment for an opiate addiction. Somewhat of the crisis that came before COVID, right? We're all living in that crisis now. He came looking because he was desperate, primarily because he could no longer afford a life-saving drug called buprenorphine. He couldn't afford it because what little money he had was for his family, and COVID had robbed him of his job, right? And it was either pay for my access to care here, or I'm keeping the lights on. Simple decision if you're a father. Prior to COVID, Jack had about 9 months clean. He was off fentanyl, off heroin, doing really well. The day before he showed up at our clinic, he had overdosed, right? And he showed up and he's looking for care. So hold that thought for a second. I'll come back to Jack. I'm board certified in psychiatry. I'm a psychiatric nurse practitioner, board certified. I'm about to sit for an addiction certification as well. About 4 years ago, I founded Access Behavioral Health and Recovery in Alexandria with Dr. Christopher Rajman, who's board certified in psychiatry and addiction medicine. I moved from Lafayette to Alexandria because I couldn't find a collaborator in Lafayette who would allow me to kind of spread my wings in finding access to care for what I do. Just couldn't do it, couldn't find it. The majority of the physicians in the area where I'm living, didn't practice under the model of providing access to this level of care for people who are on Medicaid unless you're paying a cash visit. That was the problem. I serendipitously met Dr. Rajman because of a 3-month stint I was doing just covering at a hospital. We opened the clinic in Alexandria, right, because the same group of opioid addicted patients kept cycling through. We thought we were doing a good level of service. We were providing care with his medicine, referring out to a doctor in the area. They would come back 2 months later, same story, can't afford it, back in. Some of them didn't make it back to the hospital or to the clinic because, they didn't make it. So what we did was, let's open the clinic up, right? Let's provide access to care to people with Medicaid, Medicare, insurance in general. And we were told that it was somewhat of a pipe dream given the level of grind that's associated with this level of care. But you know what? 3 months later, we're seeing about 1,700 people per month. We employ 9 clinicians, both physicians and nurse practitioners. We think we're putting a dent in Alexandria. And, whenever COVID came around, we said we're going to try to do this in Lafayette, and we did it. And what the governor did in terms of providing that emergency declaration was allowed us to open up that clinic 45 to 60 days earlier than we would have. Jack probably wouldn't have made it if we didn't have that emergency declaration. We opened up the clinic in time to provide access to Jack, and in that 60-day period, 47 other people. I can tell you that over the past year, we've serviced over 400 people through that clinic, primarily for opioid use disorder. And we're treating hundreds of patients per day through our various levels of service in Alexandria. We're providing access to care for the many who otherwise wouldn't have it. A move to make Governor Edwards' executive order permanent would increase access to care and save many more people like Jack. Thanks for your time. I'll take any questions.
Thank you. There are no questions. So since there are none, I'm going to invite the next people up. Thank both of you for coming up. Jacob Ruckall, Crescent Care in New Orleans, and Ed Timmons. I'll mention Ed, Mr. Timmons filled out a white card, but he is in favor. So if you introduce yourself.
Well, thank you, Chairman, and thank you all committee members.
Introduce yourself, please.
My name is Ed Timmons. I'm professor of economics and director of the Nice Center for the Study of Occupational Regulation at St. Francis University in Pennsylvania. I'm also a senior affiliated scholar with the Mercatus Center at George Mason University. Based on my own research on the effects of permitting nurse practitioners to practice and use their unique skill sets, I offer the following takeaways. First, nurse practitioners can help address the growing problem of unmet need for healthcare services. It is widely accepted that without reform, America faces increasing demand for primary care services and a declining supply of active primary care physicians. Second, permitting nurse practitioners to practice to the full extent of their training after successful completion of licensing requirements would improve patient access to care without sacrificing quality and reducing costs. Research consistently shows that these restrictions on nurse practitioners result in longer driving times for patients seeking primary care and reductions in the volume of care provided by nurse practitioners. In addition, researchers consistently find that nurse practitioners are fully capable of providing quality care to patients. In my own research examining how changes to nurse practitioner scope of practice affect Medicaid patients, I found evidence that permitting nurse practitioners to practice autonomously is associated with patients receiving more care without increasing costs. However, my research suggests that the positive effects of granting nurse practitioners autonomy are fully realized only when nurse practitioners are granted full practice authority. One positive effect is quite large: an 8% increase in the amount of care that Medicaid patients receive. Research continues to demonstrate that nurse practitioners are fully capable of providing high-quality primary care. Granting nurse practitioners full practice authority immediately upon successful completion of licensure requirements is a common sense reform. Louisiana would not be alone if it were to adopt this reform. Instead, the state would be bringing public policy closer in line with other states, and it would be taking steps necessary to ensure that citizens receive the care that they need. And speaking specifically to the idea of placing a cap on the collaborative practice agreement fee, that would not solve the issue of physicians being unwilling to enter into collaborative practice agreements with nurse practitioners. Only the elimination of the collaborative practice agreement will ease that ability for nurse practitioners to practice to the full extent of their training.
Thank you. I do have a question. Representative Presley, right?
Thank you for being here. I appreciate you coming down and providing your testimony. One question specifically, I think you said 8% increase in Medicaid treatment if full practice authority. Is there any rationale that you've found that provides insight into why that is?
Yeah, exactly. So if we look at the states that have granted full practice authority, you see more nurse practitioners have the ability to practice to the full extent of their training. So essentially, nurse practitioners are able to enter into areas that perhaps were underserved, or perhaps there was no primary care provider prior to the elimination of the barriers to nurse practitioners to practice to the full extent of their training.
And I guess I'm a little bit confused by that, because some of the testimony earlier today was that the only thing we're doing is removing a payment from the nurse practitioner to a doctor. I think our regulations on this are fairly expansive, so that the doc doesn't have to necessarily even be, within a certain close proximity to the clinic. So I'm just a little bit confused by that data. Is that specific to Louisiana, or is that more nationally?
This is nationally, and collaborative practice agreements, as they're written and as they're written in Louisiana, can potentially prevent nurse practitioners from having the opportunity to work to the full extent of their training. They have to find a physician that's willing to enter into a collaborative practice agreement with them.
Yeah.
So some nurse practitioners might not have the ability to fully work to the extent of their potential.
Sure.
But this law does not change anything with respect to what nurse practitioners are already doing.
And I guess I'm a little bit, again, a little bit confused as it relates to Louisiana, because my understanding from some of the documents I've been given by both sides on this issue is that Louisiana is kind of in the middle of nurse practitioner at the moment of we're not at full practice, but we're not the most restrictive either when it comes to the the practice areas that nurse practitioners are able to be in. So I appreciate your testimony and thank you for coming again.
I see no other questions. We will continue. I have no other green cards. I have some white cards, and I will. This is in white, but should have been green. 95% of Louisiana residents in primary care health professional shortage area. 40% of Louisiana citizens are currently on Medicaid. 87% of nurse practitioners are certified in the area of the primary care. This is from Johnny Koch, Scott Kilpatrick, Kerry Koch, and the Louisiana Association of Nurse Practitioners. That'll go on the record. Also, here and would like to speak, Roderick Clark, Dr. Roderick Clark. Is he here?
I am.
There you go. Come on.
Also, Chair, we might have a video
provide
issue.
Information, sir?
Yes, you're supposed to provide information.
Okay.
Okay.
Like you to take a seat.
So have a seat and tell us your name. And hold up just a second. We're having some trouble, I'm assuming.
Kind of feel like we should smile. Picture together.
These people
Okay, I'm sorry. We also had Kim Sport, consumer member. Is she here? They're both here to provide information. They turn in white cards. Introduce yourself and tell us why you're here.
Thank you, Mr. Chair. Good morning, to members. My name is Dr. Roger Clark. I'm currently the president of Louisiana State Board of Medical Examiners, and I'm here as our agency to provide you with information. On March 15th, our board passed a resolution knowing that we had seen that there may be some bills coming in the legislature that would be moved towards eliminating physicians' role in the team, what we feel is a team effort in Louisiana to provide medical care. And so therefore we passed a resolution that basically stated that it's better served, we feel as a board, that physicians remain the leader in medical care in Louisiana, and that we felt by relinquishing that role would potentially put the citizens of the state at risk. And our primary role is, of course, to protect the citizens of Louisiana, and we serve under the Medical Practice Act, as you know, and so we're therefore given the authority to discipline physicians and licensed physicians and other allied health under our jurisdiction. But I primarily came to make that statement. There is the resolution. I could read it, but I don't think I have the 3 minutes would be not enough.
No.
So I just want to go ahead and give that information. Thank you, sir.
Thank you very much. Yes, ma'am. Name, please.
My name is Kim Sport. I am the first consumer member on the State Board of Medical Examiners in the history of the board. And I thank the legislature for giving me that opportunity in 2018. I'm also an attorney, but before I was an attorney, I was a radiological nuclear medicine technologist, and I have a degree in health sciences. I have over 8,000 hours of clinical practice myself, but I would never consider myself fit to step into the shoes of a physician. The first thing that I want to mention is that the State Board of Medical Examiners has been statutorily charged with examining, licensing, permitting, and administering persons practicing medicine in the state.
And then under statute, the practice of nursing shall not be deemed to include medical diagnoses or medical prescriptions or therapeutic or corrective, of therapeutic or corrective measures. Because an APRN was going to engage in medical diagnosis and prescription management, that created the need for collaborative practice agreements between physicians and nurse practitioners. This bill removes the word medical before diagnoses and prescriptions, and also allows pharmaceutical reps to call on nurse practitioners and nurse practitioners to be able to offer free samples of pharmaceuticals to their patients, all without physician oversight. That is something that is concerning to me. This bill also provides a broader scope of practice for mental health, advanced nurse practitioners, APRNs, than psychiatrists currently have. For instance, the bill says that mental health services can be provided by an APRN over the lifespan of a patient, whereas a psychiatrist who is a full-blown psychiatrist who's gone to medical school, has done his or her internship, residency, and is practicing as a psychiatrist, if that same psychiatrist wants to begin practicing specifically in child and adolescent psychiatry, that psychiatrist has to go back and do another 2-year residency program in order to do that. That's my 30 seconds? Okay, and yes, the governor did, the governor did declare an emergency declaration. That was certainly to put all personnel on the front lines during the crisis. And the medical board, and the nursing board, as Representative Presley stated earlier, did keep the collaborative agreements in place, allowing them to move to new sites. The collaborative agreements stayed in place. I also want to say that all studies concluding similar patient outcomes for treatments between APRNs and physicians dealt with APRNs who were under collaborative agreements with physicians. There is no study about an independent APRN having similar patient outcomes as physicians. Finally, if this legislation goes forward, I have concerns. Again, I'm the public member. I think that there ought to be perhaps consideration of an incremental approach rather than a full leap from not having any collaborative agreement or physician oversight to full practice authority. I think that we can think about that. And I also think that if APRNs are indeed practicing medicine, where the word medical is taken out, perhaps APRNs ought to be regulated like those who also practice medicine, and that ought to be by the State Board of Medical Examiners.
Thank you.
As much as I can get in.
We have, thank you for your both testimony. We also have Dr. Vincent Collada, who was with the State Board of Medical Examiners. Before we do that, as he approaches the bench, come on up, Doctor. Representative Presley, I'm going to recognize you.
Yeah, I think they have questions for those two witnesses.
Oh, okay. I'm sorry. Could y'all come back up and just stay right there, Dr. Collada? We'll put them up there with you. We had a question from Representative Miller. I didn't see his light wasn't blinking because I saw Presley.
Mr. Speaker,
Jeremy,
can we put this document in the record?
Yes,
we're going to do that in just a minute.
Yeah.
All right, I'm going to recognize Mr. Miller. Go ahead, Mr. Miller, Representative Miller.
I'm sorry. What did you say your name was again?
Kim Sport.
Kim Sport, and what is your role on the medical? You're on the medical board?
Yes, I am.
You was appointed on the board?
I was.
And you taking a stance on this bill?
I'm not taking a stance. I'm providing information.
They have white cards.
Okay.
Yes.
It just sounded like you was taking a stance. I was trying to see where your stance was. I didn't think anybody on the board that was a pointed
Well,
contentious
I was
stance.
expressing concerns.
So you mentioned that the nurse practitioners was broadened in their scope in this bill. Can you elaborate on how they are broadened in their scope?
Yes, it's broadening their scope by allowing them to practice without a collaborative agreement.
So that's
Can
brought-
do that, and I was told no. I'd had to introduce it in the record, so I don't know what to tell you. Point of order. We're asking. You need them on the mic.
Okay. What's your point?
My point is, I appreciate the information only testimony, but we are asking a medical board to determine the scope of practice of the APRNs, and we've heard from the nursing board, they're the ones who regulate those practitioners. So I think some of this is out of bounds. And my point is, if they want to testify information only on the Medical Practice Act, go right ahead. But if not, let's get to the opponents, because they're going to be saying the reasons why they dislike this legislation. And I think that's what we're trying to get to.
Well, I've had a couple of I had whites on the other side too that were more. So in your point, we can't unhear.
But there were
this.
questions and answers regarding the Practice Act and complaints and malpractice suits regarding what they regulate. None of these testimony givers regulate APRNs.
Okay.
I'm getting there.
Right. Go ahead. Yeah. And
Regulate the practice of medicine.
Representative Miller, and we're going to try to be through by this afternoon.
Yes.
Go. Are you on now?
And this is the practice.
Next one. Try that.
Are we ranked last in healthcare ratings in the nation?
Yes.
And right now we're doing a physician-led model. There's only doctors who practice medicine. Is what you're saying?
No, I'm saying that under this bill and under the under prior legislation.
How long have we been practicing medicine in Louisiana? I'm sorry. Let me let you finish. I'll stop.
Okay. Under this bill and under prior legislation, APRNs were given the right to practice medicine in collaboration with physicians. This bill actually tried to take out the word medical before the word prescribing and diagnosing. I don't know why that was done, but I guess I really don't know. I guess you don't want to hear my opinions because I'm not supposed to give you my opinions. But the practice of medicine is regulated by the State Board of Medical Examiners under the authority given to us statutorily by this body.
How many of your doctors treat Medicaid patients in Louisiana?
Not many, but I do see that as a possible intermediate step to trying to curtail the shortage of family practitioners in the state.
So I think you're telling me that it's you're on record saying not many of your medical physicians treat Medicaid patients in Louisiana.
That is correct.
Do you think this bill will potentially allow more nurse practitioners to open up their clinics and treat Medicaid patients?
Yes, absolutely.
Other states, can you tell me why you think other states that currently allow nurse practitioners to practice at their full potential scope, why are they healthier than we are?
I don't know that.
So do you think the sky is going to fall if we change our model?
I do not think that the sky will fall. I am not sure that doing it in one grand leap is the best way to do it. And I do think that if we are indeed trying to fill a gap in the provision of primary care and family medicine, then we are allowing APRNs to practice medicine, and as such, perhaps they should be licensed, regulated, and whatever by the State Board of Medical Examiners, which is mandated by you, the members of this body, and those in the other committee rooms.
So you also mentioned in your introduction that nurse practitioners shouldn't be allowed to take medicine samples from a pharmaceutical rep. So pharmaceutical rep bring me lisinopril. I shouldn't give that to a patient that can't afford it?
All that I'm saying
The
is
blood
that,
pressure medicine.
All that I'm saying is that APRNs are being equated almost in every way in this legislation, as are physicians. And if you think that that's a good idea, that is your prerogative. You're going to be the ones voting.
Do you think a patient in Louisiana, a citizen, know the difference between a doctor and a nurse practitioner?
I absolutely do not. And if I would have had more time, I would have said that there probably ought to be some type of informed consent provided, form provided, so that a member of the public knows whether they're being treated by a PA, a nurse practitioner, or a physician.
So as long as the citizen know who they're being treated by, you think a nurse practitioner should be allowed to treat them if they know who they're being treated by?
With the understanding that with some understanding of the limits of education and clinical training, yes.
So maybe
I do
we
think
just
the consent
maybe
form
all of
ought
the
to say that.
maybe all of the nurse practitioners should just put a big sign in front of their building stating we're nurse practitioners and this is our limit. And it sounds like you're saying then you would agree with the bill. I'm sorry, Mr. Chairman, I'm finished.
I appreciate your attempt to put words in my mouth, but I don't think that I said that.
Thank you. All right, let's move on. And I will remind you, members, we have a meeting at 1, but we're going to continue and we're going to take a vote on this before we leave. So just so you'll know. Now I'm going to call on you right now, Representative Presley, and you have something to say. Go ahead.
I would just like to put in the resolution from the State Board of Medical Society. The State Board of Medical Examiners, which has been distributed to the members, and I'd like to make part of the official record. And I do want to point out, part of the job of the Board of Medical Examiners is to regulate the practice of medicine, correct?
Yes, it is.
And you currently have a role in regulating the doctors who have collaborative practice agreements with these nurse practitioners, correct?
In just approximately 6 years ago, we in the nursing board had a joint rulemaking efforts in that collaboration. Yes, sir.
And
so
part
we
of
do have an active role.
and part of that joint effort was to create rules and regulations that allow both to have a role and responsibility in the collaborative practice.
Yes. And the board
scheme.
does see the value of having nurse practitioners practicing. Yes, we do.
Thank you. No further questions.
All right. Dr. Pence, if you would let us excuse you. I think we're finished. No other lights on. Dr. Pence, also Karen Lyon. These are appearing white cards to provide information and to speak. Karen Lyon here. She's already spoken. I'm sorry. Mark Dawson, Dr. Mark Dawson. Dr. Collado, would you please identify yourself?
Yes, sir. Thank you very much. I'm going to do this one time, and I promise I will never do this again unless you ask me to.
Okay.
I'm going to tell you that my name is Vincent Collado. I'm the executive director of the Louisiana State Board of Medical Examiners. Having graduated from LSU Medical School in 1974, was privileged to take an advanced program in obstetrics and gynecology at the Tulane University of Medicine in New Orleans, trained at Charity Hospital, where my father trained as the first member of his family to ever become a physician, as an immigrant from Italy, went to grammar school, couldn't speak a word of English in the first grade. My mother was a charity nurse. I was raised by these people, and I trained at Charity Hospital myself. During my lifetime, I have started the first private hospital-based certified nurse midwifery program in Louisiana. I've served on the State Board of Nursing in the past. I've served over a decade on the Louisiana Patients Compensation Oversight Board. I've served over a decade on the underwriting committee of the largest medical malpractice insurer in this state. I have taught residents. I have taught medical schools. I at one time held a degree of associate professor in obstetrics and gynecology at Tulane University Medical School. I practiced and taught many years both APRNs, PAs, and other medical professionals that chose to rotate through my office by request. And during that time, I'm pleased to tell you that I advocate for and clearly understand the role of team collaboration. I've heard that this is about money. If this is about money, would this bill go away if there is no fee for a collaborative practice agreement? if this bill is about a bad collaborative practice agreement, let's look at the rules of the road. The collaborative practice agreement is nearly not about money. It talks about the parameters and the places with which a nurse practitioner could practice. When the governor waived those rules by emergency declaration, he said, you don't have to worry about the sites. We need them wherever we need them. And we agreed that that was the right thing to do. And I would recall that it was other people who thought that that rule and that order should be overturned, not the Board of Medical Examiners, not the Board of Nursing, quite frankly. I think that these rules that are in place allow for what really is about collaborative practice. It sets the areas in which we will treat patients. I have employed nurse practitioners in my practice. As an obstetrician and gynecologist, 7 out of 10 babies are Medicaid in this state. You can't practice obstetrics and gynecology. I never turned away patients because of Medicaid or Medicare. I treated all patients. And those that couldn't pay me, we made arrangements for them to get care. I've had one lady who promised to pay me $5 a month for hysterectomy. I told her, do that till you feel good about it and don't worry about it anymore. I've had patients who have offered me food, shrimp, fish to get the services. We took what we could do to make them happy, because it's important that people who want to make that kind of contract believe that they need to give something back for what they receive. They want to show the value that they appreciate the work we do. And patients who couldn't pay, and patients who said, I'm not going to pay, we did what we could to make them happy and take care of them. Now we talk about this is not about money. The collaborative practice agreement is then to set the parameters with which we say our nurse practitioners can treat our patients. My nurse practitioner had the parameter, you can do all of the uncomplicated antenatal screening, office visits that you want to do. You can treat those patients in an appropriate manner according to the protocols we established in our office. If you had a diagnosis or a suspicion of a deviation from a normal antenatal visit, you should need to call me and talk to me about it. Normally she didn't have to call me unless I was at the hospital doing a delivery. I will tell you, the last full year I was in practice in 2016 before I came to work at the board, as a solo OB with a nurse practitioner, I did 60 deliveries by myself. So I spent some time in the hospital and some time in the office. But what I want to tell you is there are ways to correct this problem and make sure that we protect the public. You do not want two standards of care. They will never be equal. And I'm available to answer any questions you might have.
Thank you. Actually, Representative Presley, you have a question.
Hopefully a quick one.
Oh.
Currently, does the...
Oh, I'm sorry. Now try.
Currently, does the State Medical Board oversee, regulate people other than physicians?
Yes, it does.
And includes acupuncture, athletic trainers, clinical...
exercise physiologist.
Yeah. And
quite
a few other folks.
Yes, sir.
Thank you.
Representative Levidarn, I was supposed to call on you and I didn't. Punch your button again, please. Well, it's not going to do that. I'm going to have to go to Representative Johnson, I believe, because he's up. Well, oh, this thing has gone crazy. Did you have your button put? Go ahead.
Is mine about
I'm sorry. You're up.
Okay. Thank you, Chairman. And Dr. Collada?
Yes, sir.
Yes, sir. I think you mentioned, you said, you asked, was this about money? And then you say, is this about the collaborative? It's about the collaborative agreement. Wouldn't you agree? I think with all the testimony we've heard today, I think this question is about access. It's simply about access. Would you agree?
No, I heard some of the members of this committee say this is about the money and the cost of a collaborative practice agreement and a detriment to the business model of the practice of APRNs. And if it's my rhetorical question is, if it's about that, would this bill go away if there was no charge?
Well, I think from what I've heard, I think access was a primary focus. Access in rural and underserved areas, those areas that have primarily Medicaid. And a lot of physicians do not accept Medicaid. Is that correct? So this bill is trying to give access to those communities who can who most of the people there have Medicaid and they're underserved and poor. You agree with that assessment?
I think that if that's an attempt, there are scientific studies to show that it may or may not help. It's not, as we would think, as obvious.
But there are 23 other states that are doing this, and they're
38
data.
that don't. Okay, so
Yes, sir.
So I think the key here is, will it increase access to care? And there are studies, and let's take one that was recently published at the meeting of the American Society of Neonatologists, I should say, that you just talked about earlier. It was done through the Air Force, which I think you would say that access in Air Force personnel and military dependents is equal, wouldn't you say? I bet that Senator Cox would tell us that. I think here what we found, the data that they reported, was in 15,000 deliveries in Air Force hospitals that they reviewed, the Air Force reported there was 70% European Caucasian and roughly 30% African American patients, all military dependents and those kind of personnel. There was a twofold increase in neonatal mortality, perinatal mortality and maternal mortality and morbidity among the African American population over the Caucasian white population. So access to care didn't change a problem, okay? It still exists. It's easily dismissed to say that's inherent bias, but there's something we're missing.
But the collaborative agreement is bringing stipulations that are, for example, in DeSoto, I heard a story in DeSoto Parish where there's a doctor, physician, and a nurse practitioner who rotates. And if the nurse practitioner's there overnight, then the doctor is there. Let's say, God forbid, the doctor has a car accident and just cannot make it to the hospital. The nurse practitioner can't call them to give care. So that hospital will have to be closed down.
No, sir, that doesn't. In our rules, the joint rules we promulgated make provisions for up to 120 days without that collaborative practicing agreement in place with another. It also requires that the physician have a backup. So those rules are in place. Now, we as an agency have had those rules in force since 2017. And we got our first complaint about those rules, the first one, this year.
But I'm saying, what you're saying in theory sounds good on paper, but it doesn't work practically in a rural communities where we're hurting to find doctors. That's why the collaborative agreement is hurting those rural and underserved communities.
Well, in DeSoto Parish, as you said, that person would not have to have a collaborative practice agreement for 120 days, and there should have been a backup already established. So what I'm telling you is, if we're going to say that rules aren't going to help, then do we really need the Administrative Procedure Acts of the state of Louisiana? I think we have these rules in place to provide the guide rails and the way to take care of our patients and protect them and assure them that there is no double standard of care.
And my closing statement to you is that they're already practicing under their scope. These rules are already in place. So they just simply wanted to remove the collaborative agreement so they can provide better service. They're paying doctors with stuff they're already doing, right?
So that it's about money, and we can do it for free.
Thank you, Chairman.
All right, excuse me, Representative Leverday, I'm going to finally get you. Sorry.
Thank you, Mr. Chair. To Dr. Galato, what game plan do we have to get more doctors to accept Medicare and Medicaid patients? Because when you speak to your board, they're going to have to change what they do and how they do it. What are you all doing? Because these nurse practitioners are everywhere. Tell us what game plan you have to put doctors in these rural areas.
Well, we could consider a number of things. For example, I'm old enough to have graduated from LSU in 1974 medical school class. At that time, LSU was mandated to accept one applicant from every parish in the state. They subsequently changed that rule. And now the older doctors like myself that went home to their home parishes are dying and retiring. Okay, we could go back to that rule, okay? We could put other rules in place. Designate medically underserved and make sure that if a person goes back to a medically underserved area, we forgive his student loans, student debt. We use the state to do that. The other thing that would get more people to take Medicare and Medicaid is if we simply said, for example, we know that there's a dearth of orthopedists that take Medicaid patients. And I know that people, as Representative Miller has said, have to send. I was about to. You're right, because I respect you. Okay, you have that nursing degree. Okay, so here's the thing: he finds that nobody will do a total knee, has to send his patients up to Shreveport. Okay, if Medicaid paid the same as Medicare, I don't think there's an orthopedist that would turn down a total knee anywhere in this state. I have to tell you, I've had 2 total knees in the last 18 months. I'm on Medicare. I'm 72 years old. Okay? And guess what? And nobody said, no, we don't want your case, Dr. Collada. Okay? So I'm saying we have a number of things that could be done, but we all have to work together. This legislature and everybody else, we can no longer afford to make winners and losers out of Medicaid providers. For example, do you know that this legislature allows preferential treatment for some providers over others, and they get paid more than other Medicaid providers? Is that fair? Do you want to address these problems? We're there to do it with you.
Are you willing to talk with the medical schools so you can put doctors so they can go back to those rural areas? Because the biggest problem we have with the nurse practitioners, they're willing to go in those rural areas. The doctors want to be in the cities.
Well, I think that sometimes if you look at that number, and there's some old data from the State Medical Society, and they can perhaps give it to you, because also in my former life, I was the president of the State Medical Society, and I was the legislative liaison for the State Medical Society for 13 years. And then we have data that we developed in the past, and I haven't seen it because I don't work with them anymore, but they have data that shows that the APRNs, much like the doctors, locate in areas where everybody wants a higher quality of life. The key is, if my family is from DeSoto Parish and I get a degree in medicine, I'll probably go back to DeSoto Parish. You know, I was born at Charity Hospital, raised in New Orleans. The furthest I ever went to get any education at all was I went to Hopkins for a 3-month fellowship and came back to Louisiana to practice.
Well, personally, thank you. I want to make sure that you tell your doctors that they're going to have to make some arrangements to get in these rural areas. Because if they don't change what they're doing, the nurse practitioners are going to take over, and you're all going to be left in the dust.
I understand that.
What you did years ago, you got to do something different in 2021.
I don't run the medical schools. I'm going to need your help to do that.
All right. Thank you, Mr. Chair.
Well, if we need to get the doctors a chance to speak, they have not yet. We've been in here for 3 hours. It's coming, though. We got Representative Selders that has his button. You do not? No. Okay. I had a blink. That's your all right, Representative Hughes. You can speak.
Thank you, Mr. Chairman. I'll be very brief. I know we're running out of time. Good morning, gentlemen. As you know and can imagine, I've received hundreds of emails from nurse practitioners and physicians, and I've taken careful time to actually read every single email that I've received. I'm going to read from one email. It's from a physician, and I won't say her name, but she cited 3 examples on why she's opposed to this bill. Number 1, a new NP graduate treated a patient for assumed cellulitis with an antibiotic that should not have been given in a full dose due to the patient's reduced kidney function. The patient received 3 full courses of antibiotics until patient was seen by pediatry, where patient was diagnosed with swelling of the leg due to fluid. She goes on to explain, and then what stood out to me, she says, collaborating physician was not notified of this patient's case and was not involved by the NP. She gave me another example where nurse practitioner with less than 2 years of experience, created some errors. And again, this physician ends by saying collaborating physician working with that NP was not aware of patient's condition and not involved. This stands out to me because if the physician doesn't know what's going on, something's broken. And there doesn't seem to be much collaboration after that fee is paid. And so if we're not going to collaborate, what's the point of having these agreements to begin with?
Well, it's like everything else. One would say this is a contract. You call it a collaborative practice agreement. When I did mine with my nurse practitioner that worked with me, not only was she had those guidelines, her office was in the same room as mine, her desk was in the same room as mine, we shared the same computer system. If I happened to be at the hospital and she called about a patient, I could pull up my computer system from my office and find out what was going on, that's what she was seeing if I needed to look at any laboratory data. The key is the collaborative practice agreement is what the two parties agree to.
Are there not uniform rules for the agreements that say you have to talk once a week, once a month, that you have to review 50% of the charts? There's no rules?
That's the point.
Well, then I'm trying to understand why they exist.
For my own protection and for the protection of my patients, did I write one that the nurse had to agree to? And I will tell you, I had one nurse that absolutely said, I'm not signing that. I said, good, I wish you the very best of luck. I'll find somebody else who will sign it and work with me like I want to be worked. Well, my patients want to be treated.
I think collaboration, again, I think there's value in collaborative practice agreements if done right. But I have to be honest with you from my perspective. Just listening, just studying this issue, I really feel like this is a money grab.
Well, like I said, if it's all about money, we could, you could, the board could, and you, with your help, pass a law or APA regulation that says they can't charge. But is that not going to solve the problem? What we really want is to have really good, better regulatory oversight over the collaborative.
Have you brought us a proposal?
It's been often said that nobody wants to do it.
That's not my question. Have you brought us a proposal?
I will.
See, we shouldn't have to wait until we get to this point. If you see something that's broken, we shouldn't always have to legislate our way out of a problem when we have these contentious debates. You should be proactive, with all due respect, if you see something that's broken. And right now, I see a system that's broken. The last thing I will say, because I know we're running out of time, I hear from physicians a lot. And it's very conspicuous to me. I have to put this on record. Over the last year, after the governor issued his executive order, I didn't hear from one single physician expressing concern, expressing a problem, saying that this is not good policy. No one sounded the alarm. And again, I hear from physicians all the time. And so now today you're opposing the bill. So why didn't, if it's not good policy, why didn't you speak out over the last year to me directly? I'm not to anybody else.
Let me say this to you. First of all, I am a humble civil servant that works in the Division of Administration.
Okay.
When the governor says this is the order,
right,
I say yes, sir. And how high do you need me to take it?
So maybe not you, but there are a lot of doctors that I'm hearing from that are not civil servants.
Well, let me tell you a humorous anecdote about why I am concerned. Maybe this will help you understand during the crisis. My wife tells me one Sunday morning, I don't feel good enough to go to church. Now, I've been married to this lady for 46 years and dated her for 5 years before that. That's an unusual statement because we went with all four of our children when they were crawling under pews and trying to get to the communion rail. My wife's a church-going lady, and when she said that, I knew she was sick. I said, tell me your symptoms, dear. I have a sore throat. I ache all over. My joints ache. I had a little fever last night, but I don't have fever now. I said, you might have COVID. Oh, I don't have COVID. We don't have to worry about that. I said, okay. I'm not going to church. I'll go. I come back from church. He says, maybe I need to go get checked. So we went to a local urgent care. We went in. I'm just Mr. Collada. I'm not Dr. Collada, just Mr. Collada. This is my wife. She needs to see the doctor. We go in. She goes in. I'll sit down. They said, oh, no, you can come with your wife. So I went in. They test her. My wife's positive for COVID. The nurse practitioner comes in. She gives my wife a set of instructions. She gives our family a set of instructions to how to live together in the home with COVID. And she said, you need to see your doctor in 3 weeks. Or you need to see your doctor in 2 weeks, 2 days if you have fever. She says, are there any other questions? Dr. Collada raises his hand. Said, my wife's 75 years old. She's just been diagnosed with a severe respiratory disease. Nobody has listened to her chest. Nobody has examined my wife. I've been in the room the whole time with her. And by the way, do you want to get a baseline chest x-ray to make sure that when she gets sicker in 5 days, we'll know what's going on with her chest? The last words out of her mouth was, we need to get you checked, and you need to be checked for the COVID and get a nose swab. If you go to the next room, we'll take care of that. My wife told me nobody ever examined her, okay? Now, I have to say that those are problems with the collaborative practice agreement, okay? That's not good. But you know what? I'm fairly sophisticated medically. The average person would not be. I know how to take care of my wife. I know what I needed to do. But I have to tell you that that's what scares me about bad collaborative practice agreements. We need to fix them. We don't need to discard them.
And what scares me is that if you see a broken system and you have not been proactive and offered a solution, that scares me. Because when we see broken systems, you should be proactive in addressing them. And I still don't see a plan. Thank you, Mr. Chairman.
Thank you, Representative Hughes. Thank you. Doctor, would you introduce yourself and tell us where you're?
Yes. Thank you for having me here today. It's an honor to be back. My name is Dr. Mark Dawson. I practice pediatrics and family medicine in Rayne, Louisiana. I am here today to present the historical context for the situation that we find ourselves in. From January 2005 to July 2018, I had the honor of serving on the Louisiana State Board of Medical Examiners. The matter you have before you has been addressed many times. Many times while I was on my 13 years, we came across this situation. 2015, the LSBME underwent a rule-making procedure with regards to physician oversight of NPs. We published rules, we put them in the state registry, and we had a public hearing. The public hearing, we had people complain. They had some things they liked, some things they didn't, including the nursing board. So we tabled that proposal. So we're going to put it on the shelf, we're going to do some more study. A few months after that, I'm called by Senator Mills to say, Mark, we got to solve this problem. Can you get with the Board of Nursing and get this problem solved? Let's get something that everybody can live with. So we did that. We go and we meet with the Board of Nursing. We meet in Baton Rouge. We meet several times, and this went over months and months and months. Some of the things in our rules, or our proposed rules rather, it addressed some of the problems you're bringing up now. We had a 30-mile radius. We said, we don't think you can collaborate effectively if you're more than 30 miles away. The Board of Nursing said, well, Mark, with the electronic medical record, we think distance is no longer an issue. You can collaborate anywhere. And we said, okay, we think you're right. So we took that out. That's not in these rules. But nevertheless, by the time we finished, we published, both the Board of Medical Examiners and the Board of Nursing, the Joint Statement of Position for Collaboration and Collaborative Practice. And in this statement, it says it is the intent of the LSBN and the LSBME to safeguard the life and health of the citizens, to provide guidance to advanced practice registered nurses and physicians licensed in Louisiana. It says collaborative practice is the joint management of the health care of patients. We included things such as the collaborating physician must be available by telephone or direct communication for consultation, assistance with medical emergencies, or patient referral at times that the APRN is exercising prescription authority. It also says collaborating physicians are expected to be available for hospital admissions and coverage. It actually went into how you did that. How do you get somebody in the hospital being referred by the APRN to the collaborating physician? It did not say that you could be 100 miles away. It didn't have any distance at all. But I think some of the questions we're issuing here, it's the same. We use the same argument. with telemedicine, I'm from Morganza, Louisiana. The guys in Neuros or the gals in Neuros could certainly see the people in Morganza doing telemedicine. They don't have to be in Morganza anymore. Telemedicine has changed everything. So we signed this, and the Board of Nursing signed it, and it's been in place since 2016, and it's in the statutes. The Board of Medical Examiners, according to Dr. Collada, and I'm not on the board anymore, so I had to call him and ask this question. The Board of Medical Examiners received 1 complaint in 5 years. My last thing is more of a personal issue, is I practice rural medicine. I practice in a small town, and I work at a rural health clinic. Rural health clinics have changed everything. The rural health clinic, the nurse practitioners are not up in North Louisiana in practices seeing patients at very, very reduced rates. They're in rural health clinics. I can tell you, my compensation, and I do a lot of peds since I'm a pediatrician and it's a lot of Medicaid, my compensation went from $40 a visit to $107 a visit overnight, as soon as I became a rural health clinic. So all of those rural health clinics are not seeing Medicaid patients at Medicaid rates. They're seeing Medicaid patients at enhanced rates because they are rural health clinics. And if you look at a list of the rural health clinics, I suspect most of the nurse practitioners in this room today work at rural health clinics. They're not up there starving to death.
Thank you very much.
Thank you.
There are no questions. I will say now these are white cards. We had green cards. These are the ones I did not read. If you can see that, it's probably close to 100. They didn't want to speak, thank goodness. So now, and I certainly, we're going to come close. I will tell you this: the speaker's going to come send for me, and the committee's going to adjourn and go down, and we're going to go to the House. When the House convenes, we'll come back when it's over and finish this up, and Representative Hughes' bill as well. So, members, that's what we'll have to do. I've had my orders. Now, having said that, we have testimony now from people who are opposed. These are red cards.
No question for me, may I leave?
Don't have a red, nothing, Doctor. Thank you.
Oh, okay. Thank you.
All right. In against the bill, we have Christopher Ford. And Matthew Giglia, I believe. Would you two gentlemen come forward and state your names and who you're with?
Mr. Chairman, I'm Dr. Christopher Foray. You heard from me earlier. At this time, I speak for myself. I'm from Franklinton, Louisiana, which is in Washington Parish, for the House, the area of Melinda White, as you all know. Thanks for having me. A little background about me that you didn't hear earlier. I was born in Washington Parish. I went to LSU undergrad, LSU Medical School. I graduated in 1994. Like Representative Emerson, I spent time in Columbia, South Carolina, where I did my residency. I could have gone anywhere in the country. I wanted to come home. I wanted to come to Louisiana. I wanted to come back because this is where my heart is. And being a country doctor like my father, that's what I wanted to do. And I had the privilege of working in my hometown for 18 years. But what happens sometimes? Politics gets in the way. Bad governance by the hospital, worse board leadership, and a parish government that didn't support us. We had to relocate our practice. We had to move to northern St. Tammany Parish. Similar demographic, take care of people there, Washington Parish, Tangipahoa Parish. But I had to leave my hometown. Our town, in a 9 to 10 month period, lost 5 physicians. So how'd they fill the gap? Allied health professionals, advanced practice registered nurses. The community didn't buy in. We maintained our practice. People drive 22 minutes or more to see me. My 2-minute commute became 22. Everybody lost. Patients lost. The hospital's hanging on, but the spirit's not there anymore. It's supported by a millage. So that's where we are. In the 5.5, almost 6 years since I've been gone, they can't recruit a physician. It's not just me. It was 3 of us with a cumulative 84 years of experience in that town. Can't recruit doctors. So where are we? Where are we in Washington Parish since 2015 when this happened. Well, Representative Johnson, we got a lot of bread and not much steak. We're number one in the state in a mortality rate for African American males from prostate cancer since that time. The other thing we've had in our parish, the opiate problem has wreaked havoc with us. We're number one in deaths and overdoses. Who wants to be number one in any of that? Nobody. So that's where we are. So, from an opiate standpoint, I'd like to share a story with you very briefly. And we'll refer to this patient, Representative Miller, from a confidentiality standpoint as Matthew. I took care of Matthew for a number of years. I watched him grow up. He went to Southeastern. Representative Bagley, for one semester. It didn't work for him. He came back to Franklinton, a place pretty much absent of economic opportunity at this point, took a job making minimum wage. He tried a pill. He liked how he felt. Then he tried heroin. Started on heroin. We talked. He was getting off. He enlisted to go in the service to protect all of us. He needed one more fix. His mother was working in a healthcare facility. She tried to call. He didn't answer. She had Find My iPhone or whatever app this is. Went to where the car was. He's not breathing. She performed CPR. It didn't work. He died. With the legislation that you all propose, controlled substances will be allowed to be prescribed by allied health professionals, APRNs. Studies have shown that they have a 20-fold increase in indiscriminate prescribing compared to physicians. We don't need another story like that. We don't need more opiates on the street. We don't need the possibility for abuse. And it's up to you all. You make this determination, because a vote for this bill may have that happen. And I don't want anybody to have the conversations that I had with Matthew's grandfathers, both of them as they cry in my office. As I tried, how do you comfort that? I don't know. And then, on the side, we had a personal tragedy in our family 3 months ago. So I asked one of those grandfathers and grandmothers, how do I get my brother-in-law and his wife through this? They started crying again. These wounds don't heal. The opioid deaths are someone's child, someone's mother, someone's grandchild. I ask for your help with this. I ask you to oppose this bill to help us control our opioid problem in Louisiana. And thank you for your time.
Thank you. Doctor?
Good morning, Chairman Bagley. I'm Dr. Ray Morrison. I'm the Dean of the Edward Vie College of Osteopathic Medicine in Monroe.
So, Doctor, don't leave. We had a question. I didn't see it on the. But just come in and we'll let Doctor speak, and we'll get back. Go ahead.
I'll
please.
go ahead and speak.
Excuse me,
then.
yes, sir.
Thank
please.
You. Good morning, or good afternoon, I guess it is now. We're getting late in the day. We came to this. We came to Louisiana because Louisiana has a paucity of primary care physicians. We know that we're number 36, maybe 37 in the United States. Now, when we talk about being number one, that's a good position to be in, to have primary care physicians in the state. We have looked at this. We were asked by the state of Louisiana to come down and look at the potential of placing a medical school in this state, therefore provide those primary care physicians and in the rural areas. So this is the solution, as we've all asked for, to help look at this. We have a track record of starting in a state in 2003 that was number 36 and number 37. It was number 36 in the nation for not having enough primary care physicians. Since that time, here in 2021, that state, Virginia, is now number 8 in the nation. One school came in 17 years and has made that much progress in providing rural physicians to the state and bringing that care. That's the reason I'm here. That's the reason why this medical school is here. And because we are providing those physicians, and what did it cost the state of Louisiana? This is a dime. And it didn't cost a dime for Louisiana to get this medical school. We came here ourselves. We talked with the University of Louisiana Monroe. We made a fun trek through the Napoleonic Code to get us a medical school on the public campus. And we put a medical school in there. I'm very proud to say that I've got 149 students right now going through medical school in 3 years to graduate, start their residency, and get 65% of those by track record of 4 medical schools. We are a system of 4 medical schools, probably the largest medical school in the United States you've never heard of. Yet, we are on a track record to put 65% of those in primary care in this state. And we'll do it from year to year. It's not going to happen overnight. I understand that. However, that is our mission. That's our goal. We practice. Our mission statement even states to provide care to the rural and underserved. And that's what we do. And we've done it in 4 campuses. We're along the Appalachian Ridge. We're in Spartanburg, South Carolina. We're in Auburn, Alabama, as I say it. And we're here in Monroe. And that forms a nice crescent, and we're right here in Louisiana. I said, well, that makes sense, to have a crescent shape when all the medical schools fall out. But just to let you know, we collaborate with the University of Louisiana Monroe with their health sciences college, too. There are 7 colleges in there, including the nursing school, the School of Pharmacy, the state's only School of Pharmacy. And we have gone through there and collaborated with all those. We have research agreements in doing that. And we plan, that's our plan. We want our students that we select from the smallest towns in Louisiana because, as it was said, you go back to where your mama and your daddy and your brother and your cousins and everybody's going to be there. You'll go back and stay there. We have 30 rotation sites throughout North Louisiana where we're going to be sending our students primarily so that those rural hospitals can actually cherry pick those physicians. And some of them will form contracts and say, we'll pay your tuition, you come back to our town. And that's okay too. It is expensive to go to medical school. Even though we're the 4th least expensive private medical school in the country, it's expensive, and we understand that. So with that, I'll yield to questions.
Thank you very much. We do have Representative Miller had a question. Representative?
Yes, just a few questions. Do you know that currently within the scope of practice, nurse practitioners can't treat chronic pain?
I do.
Okay. Do you know any nurse practitioners that own and operate pain management clinics?
I don't, but the new legislation is what the concern is.
Well, you can't treat chronic pain medicine. You can't do it. It's against the scope of practice. And I'm only asking because you seem to me like your reasoning of not voting for this was because of the opioid crisis. But nurse practitioners cannot treat chronic pain.
That was the most compelling story. I had other reasons. I am a collaborative physician. We have a new nurse supervisor in our office. I cherish that relationship. We work together. I'll ask him, what have you seen? What do we need to talk about? What happened? This is what I saw. The opiate issue was one example in this, sir.
Okay, but I'm asking, how is that an example? I mean, we even passed laws last year or year before that, if someone hadn't had pain medicine within 3 months, couldn't give more than 7 days, et cetera. So can you elaborate on where you say nurse practitioners are playing the role of causing opioid abuse?
It's
I'm sorry. I mean, I'm just
you're fine.
That was your
Absolutely.
testimony.
My statement was the concern with the opiate crisis in Washington Parish. The concern was having more potential prescribers with this, and the concern with that potential legislation, which means more substances potentially abused.
So is it accurate to say that you were saying, okay, if you have more providers, then maybe more opioids will get ordered, but you're not taking a stance that nurse practitioners are over-ordering opioids? And
Absolutely
that you have
not.
proof. Okay, we just wanted to clarify that. And also in this bill, do you see anywhere in the bill that it allows nurse practitioners to order more opioids than they order now?
In an independent practice, the potential, if we release all prescribing policies, yes, it can happen.
But within the scope in Louisiana, now you cannot treat chronic pain, a nurse practitioner.
Exactly, but I think, Representative, we're sitting here talking about an extension of scope.
How? But in this bill, does it address anything about eliminating the current practice of the scope that you cannot treat chronic pain? This bill doesn't relate to that. This bill doesn't even state anything about chronic pain management or acute pain. So I'm just trying to stay focused on the bill. My last question, you also referred to you left your parish. Some nurse practitioners came in. With this bill, how does that change what happened besides that nurse practitioner won't have to pay a physician? They currently are allowed to open. You just have to pay a physician. So how does this bill change what happened in your parish?
This bill won't change that event, but what this bill could do is further dissuade having physicians in rural areas with independent practice.
I think we can say that right now we are underserved in like 95 or 90% of our rural areas now, correct?
Look, I'm a rural physician. I understand completely. Someone who
That's a
takes Medicare, Medicaid, someone who has no control of the schedule, and actually someone who encourages people to be in Medicaid.
But Doc, listen, thank you for your testimony. Thank you for being here. I just wanted to make sure that I went on the record saying this bill doesn't do anything expanding the scope for a nurse practitioner to order more pain medicine, and it doesn't do anything to address the issue that you said happened in your parish 10 years ago. Thank you.
You're right, it won't. And hopefully at some point in future legislation, we can pass something to prevent physicians from ever getting run out of a rural parish that's chronically underserved.
Yeah, we don't want that to happen.
It happened, sir, and it was awful. And it actually happened in Tangipahoa Parish, where Representative Carter is, too.
Thank you.
Thank you for your time.
Thank you, Representative Miller. Representative Cox. Go ahead and say yes.
Sorry.
You've got them started now, Doc.
No, I had some of the same questions that my colleague had, because when you left here, maybe I wasn't hearing right, and I wanted to get it right, was that you alluded to the fact that it seems as though that the nurse practitioner moved in, and because they were there, that all these drugs were being sold.
No, sir. That was not.
You may not have intended to do that,
Not
but
my
you may.
intent. Let me clarify this.
Okay,
Well,
that's
let
what
me
I want
hold
you
on.
to
Let
do.
me get involved in this.
Yes, sir.
Because we're going to have to go to the floor, and there's no telling how long this lasts.
Oh, that's not gonna
When we
last
come
long. I
back,
just wanted to answer
you're going to
that.
you two will be up. You'll have the mic, and we'll come back and finish this.
Oh,
I
that's right.
apologize. It's just been a long time.
Oh, we
We've
gotta
had a lot of
go.
questions. So we're dismissed.
That's all right.
Down to the
We'll
floor,
get it when we
please.
come back. And I hope y'all
We're going
be
to recess till after adjournment. Thank you.
After adjournment.
After adjournment. Most folks ain't gonna be here.
We're back in. We've got one of the members, doctors left us, and that's okay. Just hold up. We're with you. Representative Carter was on the mic.
Not me.
Oh, who was? Cox. I'm sorry, my bad. It's been a long. It's been a pretty long day.
Oh, I'll tell you that.
No, you're on now.
Oh, man,
Keep talking.
So, what's your name again? Because I didn't get it.
Representative, I'm Dr. Christopher Foray
Okay.
from Franklinton.
Dr. Christopher Foray, what I was about to say, you left us thinking that nurse practitioners had flooded the country with drugs, and they can't even write pain drugs. So are you willing to make a correction to your statement that you were leading on?
Sorry, I didn't make that statement.
You didn't make it. I agree. It was the way you left. It was that they came in and the drugs went wild in your area, and so it led me, maybe nobody else, to believe that nurse practitioner who may have been the cause of that, even though I know it's not true.
As do I, sir.
So you agree it is not true.
The social determinants of health and the evolution of rural Louisiana and rural America.
Wait a minute. Hold up. Give me your 5th grade version of this. I don't want to go back to college
Absolutely.
school. Okay. All right.
I'll give
Break
you a
it
little
down.
history
All right.
lesson about Washington Parish.
Okay.
At one point, Washington Parish was the center of the dairy industry. The dairy industry went away in the late 90s. At that point, unemployment skyrocketed. Lack of health insurance.
Yeah.
Mental health issues. Substance use. All of these things that we've heard all over rural America, really. And we were a microcosm. We happen to have a more severe case in Washington Parish than other parishes.
What were your policemen? I mean, this is, I drew the question back. But that was what I was asking you about. The thing was that you left maybe a few people here with the idea that nurse practitioners came in and you had to move and then all the drugs broke out. But that's not true, and that they cannot do that. Am I correct?
At this point, they cannot treat.
Okay, and that's all I wanted to
pain.
know. That's the only thing I need you to answer. Thank you. Mr. Chairman, I'm done.
Thank you. I have no questions. Yes, I'm sorry. Representative Presley.
Doctor, I think we had testimony earlier that regarding the treatment of long-term health issues, which is not in the scope of practice of nurse practitioners, and we're not trying to extend that. But the question, I believe, that was related to that was regarding opioids. And my understanding with opioids is that it's not just the treatment of long-term health issues. There's also acute reasons that you would use an opioid. Is that accurate?
Sure.
And it's my understanding that this would allow, without oversight from a doctor, a nurse practitioner, to prescribe opioids. Is that accurate?
That's my interpretation, sir.
Thank you, sir. I'm done for now.
All right. Would you like to speak now? And actually, I don't have a card here for you, I don't think.
You do, Mr. Chairman, but I was not going to speak, and now I am. Jeff Williams.
All right. We're digging through the cards. If you would go ahead.
I will.
Thank you.
Thank you, Mr. Chairman, members. Good afternoon. Thanks for coming back to finish this day. I know it's been a hard day on all of us. First, I want to try to clean up or
Name.
Jeff Williams. I didn't say that. I'm sorry. Louisiana State Medical Society and the Physicians Coalition of Louisiana. The first thing I want to do is kind of try to wrap up some of Dr. Morrison's testimony. He had to leave to go to Dallas for a meeting. But we are very excited about what he and the folks in Monroe are doing at the VCOM school. You know, it was asked this morning, what are we doing to address rural health and physician shortages? And I'm here to tell you that school is, if it's not the answer, it is a large part of the answer. As he mentioned, they put $53 million of their own money into that school. The school itself expects to generate approximately $60 million a year in local economy in the Monroe and surrounding parishes. That's not even taking into account the financial windfall that both the city of Monroe the parishes surrounding it, and this state will get from a tax, from a job, and from a total financial output standpoint. And what I mean by that is this. We do an economic impact study every 5 years. Unfortunately, the last time we did it was 2018, so we're kind of in the middle of a cycle. But I think you'll like what you hear. Physicians in this state generate $20 billion, that's with a B, $20 billion of economic impact. They generate 120,000 full-time jobs. Many of those are nurse practitioner jobs. And they also generate 12 full-time employees. I said that 12 full-time employees making an average wage of about $75,000 a year. That is well above the state average for jobs in here. So if they are going to graduate, as Dr. Morrison mentioned earlier, 150 medical students every year, with the sole mission of going into rural parishes and practicing primary care. That's what they are trained to do. They're not trained in surgeons. They're not trained in neurosurgeons. They're trained in primary care physicians. That 150 physicians every year to this state is $180 million in total output. It's 1,000 jobs every year. It's $81 million in wages, and it is $6 million in state and local taxes. So I just wanted to follow up with that. I also have, if anybody's interested, how many physicians there are in your districts, how many nurse practitioners there are in your districts. I will tell you that is not a true apples to apples comparison, and it's not because I don't have the data. It's because some of your districts are a piece of a parish or half of a parish, so I can't give it to you exact, but I can give you an approximation. And I will tell you, I looked at the 27 poorest parishes in the state. So let me first say before I go forward, we hear a lot about health professional shortage areas. You can put 10,000 physicians in every parish in this state, and those parishes are still going to be designated as health professional shortage areas. Because the calculation that goes into that, the formula also takes into account high school graduation rates, how much fluoride is in your water, average birth weights. There's about 17 different factors. And until we address all of those parishes most likely will still remain health professional shortage areas. But in those 27 poorest parishes of the state, I looked at primary care physicians, which are family medicine, internal medicine, OBGYN, psychiatry, and pediatrics. Those 5 specialties only. And then I did my best to map out the nurse practitioners in the equivalent focus area. I believe I gave them the benefit of the doubt in some cases because it's hard to tell, a certified family, I don't want to say this wrong so nobody fuss at me from behind, but I believe you can have a designation as a certified family nurse practitioner but actually have a specialty other than that. And I think somebody can testify to that later. But 27 poorest parishes in the state, there are 663 primary care nurse practitioners. There are 643 primary care physicians. There is a 1-to-1 correlation of physicians and nurse practitioners in rural Louisiana. And I'll stop there because I'm going to take 2 minutes and I'll answer any questions if anyone has any.
Thank you. We do have a question. Representative Turner.
Mr. Williams.
Yes.
Good to see you again. I think you occupied some of my time.
I try
yesterday.
not to, but yes.
Good conversation yesterday, wasn't it?
It was.
So the most exciting thing about having that school in Monroe is the rural hospitals and this fund we have where we can pay back some of their student loans and try to keep them in the rural areas, correct?
Correct.
So we're working on funding that to take care of our rural areas.
I hope so.
I do too.
I would also add that LSU has a very robust rural track that hasn't been funded in many years, or at least hasn't been fully funded.
That is what we're trying to fund this time. We have to ask in for that.
And I will say that we are acutely aware of the financial constraints this state has been under for quite a while. But any funding that could go to, I sit on the executive committee for the nursing board, for nursing shortage in the state. And they get money every year, so we'd like to have a little money too.
I sit on the Health Works committee,
Me
so
too.
yes,
Absolutely.
we sit on there together. I'm
Yes,
brand
sir.
new, so that's one of the things we're looking at. Here's my question. I hate that I'm in a position to where I'm having to decide on this. And there's associations that should be working together on this. So I know we've been involved with leadership from the House to ask that everybody comes to the table and let's come to an agreement somehow. An agreement to where not everybody's going to be happy with the results, but to where you don't have a guy like me who's in retail deciding the fate of what doctors and nurses do. I'm being very humble here, asking that when we come to the table, we come with open minds and we meet more than once to take care of this problem so you don't have a guy in retail telling doctors and nurses what they can do.
You have my word that we will come in, my commitment that we will come in full faith to do exactly that.
Because if I'm sick, I trust this man from the last 2 years I've served with him. If I can't get into a doctor right away, I trust him with my health.
Absolutely. I would too.
And I think the agreement we have is outdated. So we need to update it. But that's me being in retail, not me being
Fair enough,
any
Representative.
studying. Thank you for being here again.
Thank you.
Thank you, Mr. Chairman.
Thank you, Representative Turner. Representative Presley.
Thank you, Mr. Chairman. Can you tell me how many doctors the VCOM medical school in Monroe, the Doctor of Osteopathy that we've talked about earlier, will graduate each year?
150.
And the mission of that school is to put primary care doctors in rural areas. Is that accurate?
Correct.
I've got a couple of maps here that show, and my colleagues here have copies of it as well. But it shows nurse practitioners and physicians on two different pages.
Okay.
And it shows, both sides have clusters in the major metropolitan areas of our state. Is that accurate?
Yes.
And obviously, we've talked a lot about rural health and the need for physicians and nurse practitioners in those areas in order to provide health care. But really, this bill is not directly geared towards just the rural health care. Is that accurate?
That is completely accurate.
Because people that have this, if the bill were to pass, you would still see more people in the big cities, the big metropolitan areas, and practicing there. Is that accurate?
I can't say it's accurate, but I would believe that to be the case for a lot of other reasons as well.
Sure. Thank you.
Absolutely.
Representative Cox.
Hello, my friend.
How are you?
How you doing today?
Good.
How long do these guys stay there? What's their requirements to be there?
4 years.
4 years.
4 years in a medical school.
4
and
years.
They will do a residency.
No.
Go ahead. I'm sorry.
I'm asking you how long, when I put them on the ground, how long are they required to stay there?
After finishing school and
yes,
going,
after finishing school.
So there's no
you can't go
requirement that they stay there, but that is how they were trained and what they were trained to do. I believe that these students, so they are opening a DO school, and I don't know if anybody here knows the difference between an MD and a DO. Both are considered physicians, but they're trained just a little differently, right? So a DO, or a Doctor of Osteopathic Medicine, takes a more holistic mind and body approach to medicine. It's not just the physical medicine that a regular MD would go through at, let's say, LSU or Tulane. Because of that, they are custom built to go into the poorest of the poor communities and the rural places and to work there. In fact, I believe the school is going to actively recruit folks, try to identify folks at the high school level.
Do you have a statistic that will show, and if you don't have one, I would recommend that you do, that shows how long these guys stay there in those positions and not move into the clusters?
So I'll give you this, Representative Cox, because I think this answers your question. So across all medicine, nationally, across the whole country, regardless of what your specialty is, wherever you ultimately train, and by train I mean you do your residency, 80% of those folks stay there. They don't leave. So if I go to Bunkie, and that's where I do my residency, 80, let's pretend there's 10 of us, 8 of us are going to stay there. And Bunkie might not have been the best example, but I'm doing the math for you.
Yeah, somebody told me some part of my family came from there.
Yeah.
But my key point here is that you gave me a statistic of, I would like for you guys to keep a statistic of how many people that you put on the ground, on the battlefield, I would call it, and how long do they stay there.
Okay.
If he stay there 1 year, 2 year, what is the requirement? I know if we have a program where you go to college, and I don't know if it's been funded lately. You said it wasn't, and you're supposed to go and you stay so many years, and then after that, you stay because you want to stay or you leave. And that's what I'm trying to get fixed in my head, is how long do these guys stay in position? And you gave me a statistic about 8 of 10 on a national level. This is Louisiana. I don't know if all of these guys are from Louisiana or where they're from, and all of these things are determining factors as to whether or not a person will stay in this turf.
Sure.
Yeah.
So to be a little more specific, I guess. So I'll speak to LSU here in Louisiana.
No, I'm talking about your guys.
Oh no, it's the same thing. It's the same model though. So for LSU, roughly 60% of the graduating medical students do a residency here, and then 80% of that number stay here.
Right.
And I'm going to tell you why they stay. It's because they meet their husband or their wife or their partner. They have children. They get involved in the local church. They have the school. They're vested in the community. They don't move for the same reasons you and I don't move. They like where they are.
I came home.
Me too. Me too. I went to Houston for several years and couldn't wait to get back here, and I love it.
I came for a different reason, but the reason is, and I ended up doing a lot of other things, which I'm here. But that's why I'm concerned, because dollars, factors, all these things can cause a person to be here or not, and then later on the situation change, a family member or something like that. I probably should have still been in Washington, D.C., but I had family members with issues, and so I came home.
I'll say, Representative Cox, and again, I'm not affiliated with the school in Monroe, and I don't want to put words in their mouth, but I do feel comfortable saying that I don't believe they would be investing the amount of money, time, effort, and resources they are in our state if they didn't want folks to stay in our state. I'll say it that way.
And I'll close with this. I still think that if you pass this on to your people, that they need to keep a statistic
Understood.
of people that come in and how long they stay in a rural environment. Thank you, Mr. Chairman.
Thank you, Representative Cox. Representative Miller.
You represent Louisiana State Medical Society?
Yes, sir.
How many of the DOs are members of the Medical Society?
Oh, so there's only about 200 DOs in the state right now because we've never had a school. 40-50% of them. They have their own association as well.
But you're saying about 100 of them
Sure.
are your members?
Sure.
So were there any resistance from the Medical Society whenever the
Absolutely
DO program came?
We 100% wholeheartedly support it.
So how does the question, should nurse practitioners pay a doctor to collaborate, how does that issue relate to recruiting physicians in rural areas?
I don't know that there's a direct correlation between the two. I would make the argument that there's nothing preventing a nurse practitioner from practicing anywhere in the state today.
So why are we discussing this medical school in Monroe and recruiting physicians in rural areas if the topic of the bill is simply, should nurse practitioners pay a doctor to practice?
My answer would be because several of the folks testifying this morning, as well as the questions from the committee, were related to physician shortages, access to a physician. And so what I'm trying to tell you, and some folks said, why aren't we coming with proactive solutions to the problem? And it may be a different problem, I'll give you that, but I think this is one of those solutions. Okay. Absolutely.
But me giving one of the medical doctors $1,500 just to practice isn't going to keep him in Louisiana, correct?
I don't believe it would, no.
Okay, thank you.
Mm-hmm.
Thank you, Representative Miller. The board is clear. Whoa, no, it's not. You snuck in there. You snuck in there again. I'm just not used to having you in committee. Thank
God some good doctors.
Representative Carter.
Good health, so I'm back in committee now. Oh, Lord. I got just a couple questions. You got the two maps?
Well, I've seen them. I don't have them in front of me, but yes.
All right. I see a strong correlation between where there are a lot of doctors, there are a lot of nurse practitioners. I see down a number that says primary care physicians 3,617, and I see nurse practitioners 4,664. What I don't see is, and what I'd like to know, how many of these nurse practitioners are not working directly in a doctor's office?
Representative Carter, I would like to know the answer to that question.
Because I know most nurse practitioners are not, like, I'm just going to take, for example, where I live, Greensburg. It's showing 2 physicians, which I know who those are. That's the 2 Dr. Monitors. And then I see 2 nurse practitioners. Well, one of those nurse practitioners works in Dr. Monitors' office. So this really wouldn't apply to that nurse practitioner. But then there's one nurse practitioner who's out there with his own independent practice, you see?
So Representative Carter, I believe, and again, I can't get the data and don't know where to get the data from, but I do believe that the vast majority of nurse practitioners practice in a hospital, a group practice, or within a physician practice, and the relationship works exactly the way it was intended to work. I do believe that. And I can't
Can
quantify
anybody,
that, though.
if anybody who wants to testify can come up and tell me how many nurse practitioners are out there who have their own office and have this collaborative agreement with a doctor, but who pretty much independently are doing their practice. Out of the 4,664, I'd like to know the number that are independent of somebody else's hospital or group practice. And I don't know if anybody can give me that number, but I think that would be a good number for us to know.
Agreed.
That's all.
All right, we've got.
Let me go this
I have no other questions. Board's clear.
Thank you, Mr. Chairman. I
and
appreciate
thank you
it.
for your service. Appreciate it. All right, Matthew Giglia, Doctor Matthew, and Dr. Giglia and Tynes. Dr. Tynes had to leave. All right. Dr. Tynes was here and wishing to speak and against. Fill out a red card. All right, Dr. Christopher Foray. I heard from him, so we know he's against it. What about this one? Brianna Schaefer? Dr. Schaefer, would you come up and speak, please?
They're just the same. Identical.
It's a little different.
Not much.
Introduce yourself and begin.
Yes, sir. Thank you for letting me speak today. My name is Dr. Matthew Giglia. I'm a colon and rectal surgeon as well as a general surgeon who practices here in Baton Rouge. I come to speak for you today, not just as a physician and not for physicians. I come to speak to you to advocate for the citizens of Louisiana. As a physician who works with NPs and PAs and other advanced practice providers, I don't have any biases against them. I have them in my own family. A little bit of my background, I grew up mostly in Louisiana. I went to medical school here. I went to college here. I did go out of state for my residency and fellowship training in 2 other states, and I came back and accepted a position here for actually a lesser offer from multiple other offers in other states because I want to be here, because I care about the citizens in this state. In residency, I did racial disparity research. I made sure that my employer took Medicaid and allowed me to take extra Medicaid compared to my partners when I came back. So I very much want to serve the underserved population and try to do that. When it comes to this bill, like was just said, there's nothing currently in the statutes that prevent APRNs from going out to the rural communities. There's nothing in there. This won't stop that in our opinion, but there's nothing that prevents them from going to Leesville, from going to Rayville, from going to the rural communities in this state. When it comes to access to care, we agree with the nurse practitioners. We agree with the advanced providers that we have an access to care problem, not just in rural areas, for minorities too. And we need to solve that. But we don't think that this does that. Now, they asked about our solutions. We have the DO school that has been brought to the attention, which is a great thing. Even, there's no consternation from the MD community about a DO school. We love having them because we need them in the rural communities. That will help the access to care problem. With the advent of COVID, we have telemedicine now. I can tell you a personal story. I saw a patient in Rayville, Louisiana, from Baton Rouge via telemedicine who was referred to me. I reviewed her entire chart, reviewed her medical records, reviewed her imaging, had a video conference over the phone with her, knew she needed surgery, booked her for surgery. 3 days later, she came down. This was in April of last year. She had surgery, went home 3 days later. Did great. I'm happy to report. We have done care for the past year via telemedicine through that. And so she is getting care, even though there's not a specific colorectal surgeon in her community. We can provide that care through telemedicine. That's one of the silver linings of COVID, that we can access communities we previously have not physically been present in. When it comes to other issues, we have the University of Queensland school that is providing education for medical students, and there's a program in place that offers to provide them to pay for their schooling if they agree to stay in Louisiana for primary care, which is great, and they go into primary care residencies. And we've been told by other residency programs that they are setting up future primary care residency positions in this state. In terms of an education issue, I know it's been said that it's not an education issue in terms of doctors versus APRNs, but in our opinion, it absolutely is. So you can't replace 16,000 hours of what I went through for education with 500 hours. Some of which may be online, all of which may be online or virtual at this point with the pandemic. And if you don't think that's happening, check social media. There's advertisements out there to obtain your DNP online only. And I have the screenshots to show to you if you'd like. We have the joint statement from the Board of Medical Examiners and the Board of Nursing from a few years ago establishing how important it is for the collaborative practice agreements and establishing the standard of care of why it's important. And it's not to protect physicians or protect nurse practitioners, it's to protect the patients. And that's exactly what that document said. And so they established a standard of care. And what they're asking you to do with this bill is supersede what they established as a standard of care in legislation, which we think is wrong. In terms of the opioids, like they were discussing, there are multiple conditions other than chronic pain that are required for opioid prescribing. And we have the studies that show that in states where there is not a collaborative practice and there is independent prescribing authority for nurse practitioners, they do have an increase in opioid prescribing. That's a study that's been done. That's not like conjecture. That's just what we have in the medical literature. I also want to speak to you on a patient level. I have 5 kids. So this comes as a patient, as a father. My daughter, 2 years ago, was less than a year old, and I was at work. My wife was at home with her. She's one of 3 triplets that we have. And she began having a seizure, lost a pulse, turned blue. And my wife is a NICU nurse, luckily. Called 911, started CPR. Paramedics arrived, thank God. Got my daughter back, rushed her to the hospital. I met them there flying on the interstate to another facility where I'm not a physician. And I did not, pretend to be one at the time. And, I looked up when I was watching my daughter getting cared for by nurses, by NPs, by the ER physician, by the pediatric neurologist who came down because of her seizure. I did not once worry that there was someone more qualified to take care of her. I was allowed, even as a physician with all my knowledge, knowing she was in the best hands possible in that situation. You have to allow the physician-led teams to continue to promote that care because that's what the patients deserve. We should be building bridges, not silos. You take away the collaborative practice agreements and you're going to have 2 standards of care, like Dr. Collada said. You're going to have 2 teams, and that is not what we need in the state. We need to work together. We're all on the same team. We all want to take care of the patients. This helps us take care of those patients. When we agree there's an access to care issue, let's work together to solve it, but let's not end our agreements between the practices doing that.
Just on time. Thank you. Representative Presley, you had a question.
Doctor, I understand that you have some experience with credentialing at a hospital. Is that accurate? Could you tell me the difference in the credentialing for nurse practitioners versus physicians?
Sure. So at our hospital, I can speak to my hospital only because that's where I serve on the credentials committee. We have a standardized committee of both APRNs as well as physicians that meet for the credentials committee. We have a standard form that they have to fill out that has to be approved by different levels, including the chiefs of medicine or surgery, including the credentials committee, including the chief of staff. And they apply for privileges and credentials, and it's up to the committee to decide whether they are actually granted those privileges. And with APRNs, it is not independent practice at our hospital. It is under the guise of a collaborative practice agreement. So they don't have the same credentials and privileges as a physician does.
Thank you.
Thank you, Representative Presley. I have no other buttons, so we're finished with that, I guess. Ma'am, doctor, would you introduce yourself, tell us where you are?
Good afternoon, Chairman and Representatives. My name is Dr. Brianna Schaefer. I am a first-year resident in Alexandria, Louisiana, practicing as a first-year physician. Prior to my testimony, I just wanted to tell you that I am a non-traditional medical school graduate. Everybody in my family was in the military. They're all pilots, including my mother. So when I chose to go into medicine at 30 years of age, my family was not happy about that. But I would like to make it very clear that I fully support and really value the service that nurse practitioners provide, so much so that I even supported my sisters financially and otherwise to pursue their own degrees to become nurses and then nurse practitioners. I even delayed my own education and entrance into medicine to ensure that they would have a pathway to success. So the biggest thing that I want to talk to you guys about today is that I believe every single person in this room and every person watching on TV right now agrees that every single patient deserves access to safe and competent care. That means we also have to pay special attention to some of the needier populations, minority populations. I'm half Hispanic, so I'm here to provide a service to those patients and also patients in rural areas. I myself am not a native of Louisiana, but I have lived in several parishes in Louisiana, completed my medical training in Louisiana, and I chose to pursue a rural medicine practice as a family medicine physician here after falling in love with Louisiana and then maybe a Cajun, but Louisiana first. So for your review today, I have something I would like to submit because I would like to address some of the discrepancies and misunderstandings about what it took for me to get here, to become a doctor. In the piece of paper that you'll be presented with today, you'll see that my own pathway to become a family med physician is quite different than the pathway that my sisters chose to become a doctorate in nursing practice. I will be required in the next 2 years to have completed actually 18 to 20,000 hours of training to become a family med physician. Along the way, I have been required to complete not 1, but 4 tortuous boards before I can even have the privilege to sit for the 5th and final with the American Board of Family Physicians and stay here in Louisiana. Only after that board may I practice independently. The point I'm trying to make today is that I stand before you today as a medical doctor, an MD, with those 2 letters behind my name, and yet I still have to practice under the direct supervision of other physicians for the patient care and safety. That includes prescriptive authority and direct patient care. This is to ensure that I'm providing that competent care to those patients and to ensure their safety and that they get the care that they need. I do not practice under a collaborative agreement. Even after all of this training, if at some point I decided I wanted to be a cardiologist, I would have to do a whole nother residency and take a whole nother set of boards amounting to another 7 years of training. So with that in mind, I would just like to say I am deeply concerned that the passage of this bill may discourage people like myself from wanting to go to medical school. I believe the DO school has a great solution to help with our access problem here in the U.S. and especially here in Louisiana. And I'm hoping that most of those people will stay here like I did to practice. Thank you.
For your testimony, thank you. Representative Presley, you have a question, right? No? Representative Labradine, excuse me. You do, yeah, go ahead.
Mic check. Thank you, Mr. Chair. Dr. Gilio, you indicated that nurse practitioners are taking courses online. Go into specifics about that. Explain what's going on.
I can't explain the specific online courses. I can only explain the advertisements that you see on social media of multiple organizations promoting getting a DNP from home, going from RN to nurse practitioner online. During the pandemic, it's our understanding that a lot of these clinical hours have been done virtually as well as through simulations, which without actual physical patient contact.
And they're required to, I guess they're able to go to able to go to class for so long, and they're not getting any hands-on treatment or touching patients.
That is what they are advertising. Yes.
Ooh, that's scary. How do we encourage more physicians to make the challenge for Medicare and Medicaid patients and participate in those underserved communities, minority communities?
Right.
How do we get them in there? You mentioned that you're doing a lot, and you're making this step to provide medical treatment for Medicare and Medicaid, and for challenged communities. How do we get other physicians to do the same thing?
Well, I think the DO school is a big role in that they're going to go to these underserved communities that primarily have Medicaid and Medicare populations. I think the telemedicine is exceptionally important for these patients, in that the CMS guidelines have changed for telemedicine visits to actually and encourage physicians to incorporate telemedicine into their practice to where they don't physically have to be in the specific location but can virtually see those patients and treat them.
Okay. Thank you, Mr. Chair.
You're welcome. Thank you, Representative Laverdane. Representative Hughes.
Thank you, Mr. Chairman. Let me thank both of you for your testimony. It really means a lot, and I really value your expertise, and thank you in particular for your dedication to underserved communities and communities of color, because we know that there's disparities there. Doctor, you said something that stood out to me. You said that should this bill pass, you're concerned that it will discourage people from going to medical school, and I guess making the shortage of physicians worse. I guess roughly 22 states don't currently have collaborative practice agreements. I'm just curious, have we seen a shortage of physicians? Did it worsen in those states? Can you talk to me about that? Do we know?
Absolutely. I can't tell you any about the specifics regarding the states that don't have, the agreements in place, and if it's actually alleviated or worsens the shortage. And quite frankly, part of that actually is because we just don't have enough data. Okay, a lot of those collaborative practice agreements have had major changes to them, some minor, in the past 5 years especially, to address shortages, of course, in rural healthcare and minority healthcare. We just don't have enough data yet to show, and part of that is also because we have an enormous amount of physicians retiring, and we also have an enormous amount of new physicians and graduates like myself who are non-traditional who went into medicine and have even started attending the new DO schools throughout the U.S.
Okay. Thank you very much.
Welcome.
Thank you, Representative Hughes. Representative Miller.
Clean up. I just got to keep playing clean up around here. Hey, thank both of y'all for being here. I really respect you a lot. I know it's not easy to come testify, but thank you for treating Medicaid patients and serving in Louisiana. I do have one question. You mentioned you have supervision. Do you have to pay for your supervision?
No, I do not. However, as a medical student, I actually did have to pay for that supervision.
Okay.
And I will say, with two sisters that are in NP school, one who's doing hers online, by the way, and the other one who's doing hers in person, I had to pay for every single rotation that I attended in addition to my tuition, which amounted to an extra $22,000 on top of what I had to pay.
So let's focus on this online stuff that you couldn't elaborate on, but you said you've seen it. I just Googled medical school in the Caribbean. I don't even need to take an MCAT. Mm-hmm. Should I judge you because you can Google it? It comes up.
Yeah.
Should I judge you of something that I see a physician can take a PAT?
Right.
This total online school stuff is totally not what y'all are trying to sell it to be.
Well, I think that's
so we need to be more factual whenever we're saying stuff, because that it's making representatives up here believe, oh, well, you can just go buy a degree online. That's totally false. You have to do your clinicals in person, etc. But that said, I don't have any questions.
I think that's a good. Can I respond to that?
Yeah, he needed to respond.
I am going to let you respond to him, and thank you. And you're going to need to restate your name when you get started. So go ahead.
Yeah, I think that's a good point about the Caribbean schools. They are MD schools, and some are DO schools down there. They may not have to take the MCAT, but what they do have to do is actually take the CEP exams to be admitted to United States, and then go through a residency program here. So there's actually a very standardized set of regulations that are required for physicians who don't actually obtain their medical degree in the state or in the country that have to want to come back and practice in Louisiana. I don't know that there is that same standardization across the nurse practitioner spectrum.
There's
in other
one
states.
standardized national test. Yes, sir. And you have to do your continuing education hours. You have to recertify in 5 years, ANP, et cetera. They have a standard that's set. So, and listen, I don't want to go back. I respect you. I really do. So I don't want to go back and forth. I just want to try to stay as factual as possible here today. And you said it yourself that you just saw it as an advertisement. You wasn't sure what was going on. I just need the members here to know that that's not accurate.
Well, I guess my question would be, I can pull up the advertisement for it and we can go through it. I just, just because I didn't have a specific experience in medical school doesn't mean there's not a medical school out there doing something new that I didn't go through.
Yes, sir.
And I would say that maybe the pandemic has shifted that they are now doing these things online, which again decreases their direct patient care, which that's what they're advertising. I'm not trying to put words in their mouth. That's what I can show you the pictures. Like it says, get your DNP from home.
So LSU during COVID is not doing any any online courses. LSU Medical School. They're on right now. COVID is going on. You don't believe they have any online courses happening? Not one.
They have, in my understanding, I do not know the answer to their curriculum, but I would say that as a physician, I would want them to have in-person care.
Yes, everybody.
When they're training.
I agree. No, that's a mutual agreement. I'm finished, Mr. Chairman.
May I clarify that? I'm actually a Caribbean school graduate.
Oh, thank you, Representative Miller.
I wasn't trying to insult you.
No, I just want to clarify. I
just
just want to clarify so that everybody here understands something. There are schools in the Caribbean that do allow you to apply without an MCAT. That is correct. However, you cannot go directly into an MD program. You actually have to do a 2-year program of basic sciences education, and then you sit for an exam that is similar to the MCAT that is usually determined by the state, or in some cases the country where you are attending medical school. I went to SEBA. So SEBA, American University of the Caribbean, Ross, and also Medical University of America, and finally St. George do require an MCAT. And not only that, they require a minimum score in order to attend the school. They don't have one of those preparatory programs. And you have to be in seat 90% of the time in person. They do not have online courses.
And listen, thank you for your clarification. I was more showing him that I can Google and find the same things he's finding about bad medical schools. And if we wanted to explain the online, we do have Ms. Karen Lyons, the executive director here, but I don't think the committee even wants to go there. But I was just trying to make a point that I could Google where it says no MCAT required, go to the Caribbean school, X amount of years. So let's just state facts. Thank you.
Thank you again. Dr. Williams, did you want to
Not a
jump
doctor,
in here?
but thank you.
Mr. Williams, there's so
night.
many. I mean, we're on the doctor's side here.
I know. Jeff Williams with the medical side. Just to clarify some of this. You can go to Google right now and type in Doctor of Nursing Practitioner and find no less than 9 schools, none in Louisiana that I know of, but 9 schools that offer a full online only. I've talked to 2 individuals who went on campus twice, once to pay their tuition, once to pick up their diploma. Never saw a patient. I will not speak to what the medical schools are doing during COVID because I do not know. But I do know that there is not a single medical school in this country that has gone to a full online 4-year degree or a 2-year or anything. When you talk the next level about the Caribbean schools, there are medical schools all over the world. But you know what happens when they come here to Louisiana? They don't get a license, at least not right away. They are required to jump through additional hoops, complete additional documentation, maybe take additional education, additional training. A physician is not a physician is not a physician. They are all, I heard someone say this morning they are very broadly trained. That is absolutely false. They are very specialty trained. If you look at the competitive nature of physicians in general, right, they all have the exact same personality. I work with them every day. But, the acceptance rate is like 3% of the applicants actually get in. You have to have a 3.8 in a science undergraduate degree. Some of these Doctor of Nursing programs online that you look at, 100% acceptance rate. I, with an engineering background, can apply and get accepted tomorrow, and 2 years from now, I'm a doctor of nurse practice. And I don't want to argue with you, Representative Miller, but it's on there. That you can go with any degree and complete 2 years online training and be a doctor of nurse practitioner at these online schools. Go online and look. You do not have to have a BSN for all of them. I don't want to argue.
I'm going to put you.
I don't want to argue.
I'm going to put your.
So we have nursing board executive director here. Let's get rid of this.
I'm talking.
No, I want to go on record as.
I said not in Louisiana. I did say that. I said not in Louisiana.
I want to talk about Louisiana nurse practitioners.
Then I'll rescind my comment. I said
Let's
nationally.
just state facts, man.
It is
There's no nurse practitioner in Louisiana that can get a nurse practitioner degree without doing direct patient-to-care training.
I will agree with
Can Dr.
Yes.
Lyons come and speak up on this, please? Because I think it's important, Mr. Chairman, to state facts.
We have to maintain decorum in this room.
I'm going to maintain decorum, but we have to state facts. I mean, the stories he just gave were completely false in Louisiana, and I'm just asking for the executive director of the board to come and speak on it. She's here. And he admitted that this is false.
No.
Speak truth, man. Speak the truth.
All right.
You are under oath.
I have
under oath.
And I stand by what I said under oath.
all right. With that said, let's call the next.
Yes,
folks.
sir.
We don't have any more questions there. We need William Clark, Dr. William Clark.
I
is
believe
here.
he left. He's the coroner here in town. He had to go to a case.
Okay. Lisa Casey, LAFP, is here. Dr. Kenneth Brown. Dr. Kenneth Brown, is he here? And Dr. LaBaugh, you just as well come up and have. Well, I know, but you can come up now and talk and just wait your turn. I hate for you to go by yourself. Would you, ma'am, would you start first, your name and what you do, where you are? And
Yes. My name is Lisa Casey. I am a family medicine physician. I'm the program director of a family medicine residency. I am Louisiana born and educated and trained and now working physician. I finished residency and joined the faculty and then became the program director. So I've been asked to really speak toward the education of physicians and because I think the pause in some of our objection to this is that there is not the standardization of education or of training for nurse practitioners as much as there is for physicians. And to begin with that, I know someone testified earlier about that they have their 5 lanes and they stay within those 5 lanes because they know their scope. But that's not exactly the case. I think there are more than 5 lanes because, especially in FNP, can work in cardiology, can work in orthopedics, can work in nephrology, really can and dermatology, and so in that, and when they decide that they don't want to do that anymore, they can just switch to the next thing, which everyone knows, and I think has been stated more than once by the physicians who have come up here, we certainly can't do that. That's years of training and more board certification. But more to the point that there's a reason that we can't do that. We can't do that because that is not safe. Because treating someone for cardiologic problems, treating someone for their kidney problems, treating someone for their orthopedic problems takes specific training. And so if you can move from one office to the other office with no change in training, that is not safe for your patients. And this particular bill will not only continue to allow them to do that, but to allow them now to open an office and say, I am cardiology, I am neurology. So when you are a DNP and you have doctor on your coat, the patient has to be pretty savvy to understand the cardiologist I'm seeing is fellowship trained versus a nurse practitioner now practicing completely independently. So that's a major concern for patient safety for us. So while I realize there are many primary care nurse practitioners working in rural areas and really filling a need there, what this bill will do is open up a Pandora's box in the areas that are flooded with healthcare professionals to be able to open up a dermatology clinic and offer treatments and or infusions of hormones that really are completely unsupervised by a physician. And those are things that are very specific specialty trained things. I know she had given you the handout about the number of hours, and everyone understands that and neither of us are saying that it's equivalent and that they're trained in nursing and practicing to the top of their scope, but it's not only the number of those hours, it is the quality of those hours. So they have to have at least 500 hours, if not more, of clinical training. That clinical training varies across schools. It's not specific, and you have to have this many procedures. You have to be able to do an H&P. You have to touch this many patients or have this many encounters. I know this because as a family medicine physician, I'm getting cold called all the time for people who have to find their own rotations. And so there's no requirement of what specialty that person has to be in, what qualifications as faculty. I mean, I hire the faculty for my residency, so I know exactly who is teaching the residents, and that is governed by the ACGME. So and for residents, you not only have to continuously have that true oversight where your faculty is watching you, you're continuously evaluated, but it's a specific, like I was saying, a specific number of encounters, a specific number of procedures and tests. So I think for us, we need to know that there needs to be a standardization of that training. So like Dr. Collado was saying, there's not two standards of care. It's if you show up and somebody's treating you for a cardiology problem or an orthopedic problem, you have a baseline knowledge, a baseline confidence as a patient that you are being cared for appropriately. I think I probably am.
Thank you. Yes, I'm probably so. Representative Johnson has a question. Representative.
Doctor?
Lisa Casey.
Thank you, Dr. Casey, for your service. Just a quick question. Can a nurse practitioner practice cardiology?
There are cardiology nurse practitioners, yes.
So that falls within their scope of practice? I didn't know that. So you're saying they can practice
They
on the heart?
certainly are seeing our patients in the hospital as the cardiology consultant. They are under a cardiologist. My point is, this would make them not be under a cardiologist.
Chairman, I don't know if that's what I've read through my report and my evaluation. Can anyone who's with the nurse practitioner just answer that question? Can they practice cardiology? I just want to know, because I think there's just a lot of false information we're getting. It's not good. They're throwing things out there and confusing the members with bad information.
Possibly that has already occurred, and we're trying to correct that.
Well, I will say we've had a doctor, I'm assuming a doctor. That's
No, sir, I'm a family nurse practitioner with a master's degree.
Okay, and
He asked for
I
someone
had
from our
Dr.
nurse
LaBelle raise his hand. So I'm going to go down the row, and Dr. LaBelle, you have a insight here.
Hello, my name is Luke LaBelle. I'm an emergency medicine physician. I
Well,
practice in New Orleans and Homa both, but I just wanted to make one comment on your question that in other states that have independent practice, nothing prevents a nurse practitioner to open an office and hang on the door a sign saying, I specialize in cardiology, and actively advertise seeking out patients with cardiology issues. My understanding is if we remove collaboration within Louisiana, there will be nothing in statute or in regulation that will prevent a nurse practitioner through the family medicine track to open up a clinic and hang on the door and say, I am an expert in dermatology, in cardiology, in whatever. This is my understanding of the possibilities of this legislation.
Okay.
All right. Are you a proponent or opponent?
Proponent. I was asked a
Already
question.
had the proponents to speak.
A question was brought forth by the representative if someone knew if a nurse practitioner just go ahead
Well,
and
I'll
sign
tell you what,
the
I'm going to go ahead. If you have an answer for his question.
Yes, sir, I do.
Go ahead. Proceed. Now, we'll need a name and your.
Herndon Johnson, Buzz Johnson. I'm a family nurse practitioner in the central part of the state.
Go ahead.
The answer to the question is we practice within our scope of practice. We go through rotations within school with cardiologists. Some go with gastroenterologists. We go with different aspects of family practice. When we go through those, we learn and we understand our scope of practice. So can we work with a cardiologist in cardiology? Yes. As a family nurse practitioner, do I know enough about cardiology to be able to examine the patient, find out if the patient has a diagnosis that needs to be furthered? Yes, I do. Will a nurse practitioner go out and hang a sign on their building saying they are expert in cardiology? No. It's not within our scope of practice. It's not out there. We're not trained to be cardiologists. We're trained to be within those lanes that we talked about. Those lanes will be hung on our door. I'm a family practice nurse practitioner. That's what the sign is hanging on my door. We don't have cardiology specialists in nurse practitioner school. We have plenty of advanced practice nurse practitioners in critical care that know a lot about cardiology, but they're not going to go out on their own and open a cardiology clinic because they're not cardiologists. Does that satisfy your question?
That makes sense. Thank you.
Ms. Lyon, you've already been in. You've had a card, and you're here for information.
I am here
so
for
if
information.
you would give us some information, please.
Yes, sir. Can everybody hear me? I can't tell on.
Yeah, we can hear you.
So I'm going to address your question.
We're going to need to introduce yourself again.
Karen Lyon, the executive director of the Louisiana State Board of Nursing. So absolutely not would a family nurse practitioner in this state be able to come and hang out their sign and say that they were a cardiologist nurse practitioner. First of all, there is no testing and certification for cardiology nurse practitioners, nor emergency room nurse practitioners. There's family nurse practitioners, adult health nurse practitioners, acute care nurse practitioners, primary care pediatric nurse practitioners, acute care pediatric nurse practitioners, acute care adult nursing practitioners. But those are the roles. Okay, as Mr. Johnson said, many of them work with cardiologists or nephrologists. They work with gastroenterologists, endocrinologists. So they may have some aspect of that care if they're treating diabetic patients or patients with hypertension. But no, the board would not allow that. It's not within their scope, and they cannot represent themselves as a specialist. We would take disciplinary action against them. Okay, so now I want to go back and address the DNP issue. The DNP online social with no clinical no clinical hours whatsoever. We would never. First of all, the state of Louisiana has invested in the State Board of Nursing the ability to approve all undergraduate, pre-licensure, and APRN programs because they lead to a second license. And so we regulate those. We would never, we have never and would never regulate or allow an online program that did nothing but didactic classes online and they never saw a patient. It wouldn't happen. It hasn't happened, nor if they wanted to endorse into the state of Louisiana, they would not be allowed to do so. Because to endorse into the state of Louisiana and receive an APRN license, you have to meet our standards. Louisiana standards. And if you're in your credentials evaluation, when you apply for endorsement as an APRN into this state, if your educational background has not met those requirements, then we don't endorse you in. We've already taken those actions against nurses from foreign nursing schools that come here that don't meet our credentials. And so even as an RN or an APRN, if you don't meet the requirements that we have for our programs, you won't be credentialed here. So I just wanted to make that clear.
And we appreciate the information. Thank you very much.
Thank you.
Now, who's Dr. LaBalle? Who have you finished Europe? You hadn't had your 3 minutes yet. Has he had his 3? And I've got Representative Presley would like to speak. From Ms. Lyon?
Ms. Lyon, or Dr. Lyon, I believe. Correct. Which is it? Is it doctor or miss?
Professionally, people refer to me as doctor. You can
Dr.
call
Lyon.
me Mrs. Lyon.
I'll go with the
Call me
professional
Karen.
one.
Okay.
I appreciate it. I understand where we are right now with the credentialing of this industry, right? And saying that nurse practitioners are not cardiologists but there are nurse practitioners that are in the cardiology field, correct?
They may work with cardiologists, yes, sir.
And I guess, part part of my concern is that this opens another door 10 years down the road or 5 years down the road, like we had with the optometry versus ophthalmologist debate with lasers and being able to, I mean, those two roles are very different. There's vastly different training, but that was a part of the conversation a few years ago. So is it the position of the board that as we move forward, that will never be requested?
It's the position of the board that we license advanced practice registered nurses in one of 4 roles, that being nurse practitioner, clinical nurse specialist, certified nurse midwife, and certified registered nurse anesthetist. Those are the 4 roles that we license people in, and that we accredit those programs here in the state of Louisiana for those 4 roles and for a population, a specific population. So particularly for nurse practitioners, they work in different populations. Obviously, the pediatric primary care nurse practitioner works with pediatrics in primary care. There's also primary pediatric acute care nurse practitioners that work more in the hospital with acute exacerbations of pediatric conditions.
And I guess my with the Board of Medical Examiners, if you're a rheumatologist, you're a rheumatologist. There's a different certification for that versus being a internist or a family medicine doctor. And if the nursing board only certifies for these 4 roles, and then there's classes that are taken within those 4 roles that we're now holding people out to be nurse practitioners of whatever specialty, there's a difference there. Do you see I've got a little bit of a concern on that front.
Well, no, I'm not concerned at all, because we have the license is for a family nurse practitioner. Okay, the license, they take a certification exam as an FNP. They take a certification exam as an acute care nurse practitioner. They take a certification exam as a primary care pediatric nurse practitioner. They take a certification exam as an adult health gerontological nurse practitioner. They take a certification exam as a women's health nurse practitioner or neonatal nurse practitioner. There are many subcategories of nurse practitioner, but when they are licensed through us, that's what they are licensed within their role in population.
Okay. Kind of switching gears a little bit. One thing that our legislator did last year was we provided a licensing basically from other states, and I believe nurses are now in the if you're I'm blanking on the name, but it's there.
Nurse
you can transfer
compact.
Exactly.
There is no advanced practice nurse licensure compact at this time. It's been introduced, and there have been, for the new APRN compact, I believe 3 states, maybe two to three states have passed it. There's legislation in different states for it to go forward. In order for it to become activated, at least 5 states have to pass it. So that will be done. In order to have the APRN compact in any state, you must have full practice authority. That's one of the requirements. Now, having said that, I want to go back because you were asking about the nurse licensure compact. We have the compact. It's for RNs. Mm-hmm. It's the RN nurse licensure compact. If you want to practice in the state as an APRN, you still must get an APRN single state license from the state of Louisiana. You must meet all of our requirements. So if you go to a school that doesn't meet our requirements, we will not license you.
You knew exactly where I was going. Thank you.
Thank you very much. Anything else while I'm here? Thank you.
Hey, I'm back again.
Thank you, Dr. LeBeau.
So I have a couple of statements that I want to make that, again, my understanding, and I am very open to having somebody explain to me if my understanding of things are different. But like I said, my name is Luke LeBeau, emergency medicine physician. I'm here representing the American College of Emergency Physicians. I'm on the state board locally. I'm also on the national council, the governing council for ACEP. ACEP has a standing policy statement that states that they want physician-led care. Nurse practitioners and other mid-levels are a very important part of the healthcare environment. We don't want them to disappear, but we want them to be in a physician-led posture with some very heavy, dedicated education that the physicians can tune them towards for the specialty that they're practicing in. So for emergency medicine, there has to be a doctor there has to be a doctor in-house, and the nurse practitioner needs to have very specific continuing education on emergency medicine topics to practice. That's the national emergency medicine kind of view on all that. I work with nurse practitioners. I work with some phenomenal nurse practitioners, and I'm going back towards their education level and their practice habits. Physicians do much more education. We're talking 18,000 hours versus 600 or 700 hours. A third-year medical student has the same level of education that a nurse practitioner has at the time of graduation and licensure. Would any of y'all like a third-year medical student taking care of y'all? I have nurse practitioners that I work with every day, 3-4 times a day while I'm working with them. They're excellent, and they walk up to me and say, "Hey, Luke, I got this that I want you to look at." They drag me into a room. They say, "This is a patient that I'm not sure about." They are very algorithm driven, and they have a superficial understanding of pathophysiology compared to a physician. I agree. A nurse practitioner and other mid-levels can do 60 to 70% of my job. No sweat. They are phenomenal at it. And they can do it, and I will never take that away from them. But a physician-led team catches that 30 to 40%. The rare cases, the complex cases. I've had nurse practitioners miss a condition called necrotizing fasciitis. They thought that it was just a cellulitis case. And this was a patient that I was just walking by the room and glanced in, and I jumped on the case because that's a life-threatening disease that we had the patient in the operating room in under 30 minutes. The nurse practitioner was getting prepared to discharge them home. I've also had mid-levels and other advanced practice PAs from urgent cares that are sending people to the emergency department with wrong diagnoses, with completely wrong 12-lead EKGs. And so a physician needs to be there. I'm actually a fan of going past collaboration and going back to a supervisory role. I know that's going to raise a whole lot of hackles that's in this room going backwards in that way, but they are great in the role that they have. But the role that they have is limited. They need physician oversight, and they need to have a physician that they shouldn't maybe kind of call, but a physician that's involved and that they do call, and that the physician does chart review, education, the whole thing.
Thank you very much, Doctor. Representative Johnson, you have a question.
I'm sorry, what's your name again, Doctor?
Luke Labat.
Dr. Labat. Well, so first of all, I want to go on record and say thank you for what you do. I respect what you do, and I respect what every single frontline worker did in the pandemic. So I don't think anyone have any superficial views on anything. We got to respect each other and what we do. With that being said, can you just tell me what's the process? Because I think there's a misunderstanding here. I don't think some of the doctors and nurse practitioners or even registered nurses, I don't think there's not an understanding of each other's role or education requirements. Can you tell me what a nurse practitioner requirements are? Have you been here all day?
Yeah.
Tell me how to become a nurse practitioner.
I'm going to tell you my understanding, and again, I'm very willing to be corrected on this, okay?
Mm-hmm.
And there's minimum standards that are in various states. There's standards to this state in particular. But my understanding is you need to have a BSN, a Bachelor of Science level registered nurse practitioner, okay? Then you can apply to a nurse practitioner school. Some of them are actually excellent schools that are in-house, live didactics with considerable amount of clinical exposure as part of the curriculum. There are some other schools that, again, I'm willing to be corrected on this, that their didactics are 100% online, heavy on online simulation. There is a requirement in most cases for clinical experience, which is shadowing a doctor at the minimum. And the nurse practitioners need to seek out, if the school doesn't have prearranged docs to work with or other nurse practitioners. They have to seek out cold call physicians. I've had nurses that I work with ask if they can follow me and shadow me. And in a shadowing stature, they just follow me around. They don't touch a patient. They don't develop a history.
Do you have respect for the profession?
I have a respect for a well-educated nurse practitioner that has taken the long way around. An experienced nurse with several years as a nurse working in critical care, working in emergency medicine, that then goes to a good, accredited, live, in-person didactic, hopefully a university or a nursing-based school, not going to Herzog or not going to DeVry, but going to a well-positioned school that then has an appropriate number of clinical hours, not the minimum 500. They need, I did 18,000 hours of clinical education. That's on top of my 2 years of didactics. I'm not asking them to do 18,000 hours, but it sure as hell needs to be a lot more than 500 hours.
Okay, and do you know what an opinion is?
Sir?
Do you know what an opinion is?
Yes.
Yeah, I'm asking that because I want to go to a nurse practitioner just to get my blood pressure checked. You think they're not suited to do that?
As I stated earlier, a nurse practitioner can do 60 to 70% of my job and do it well. I have no problem for uncomplicated maintenance issues, a twisted ankle, even some fracture care, I&D abscesses, laceration repairs. They can handle this stuff and they can handle it very, very well. But I also want it to be having close physician oversight so that if there is a problem, they can more easily bump it up the chain as opposed to a collaborative practice or an independent practice where, gosh, I sure hope they bump it up the chain. Chart reviews are a big part of this. With the collaborative practice, the physician doesn't necessarily have to dig through their charts and make sure that they're keeping a standard of care.
Yes, sir. My closing statement to you is that this is a very important issue, and I think that we're going to have to all be open-minded with one another, respectful, understand each other's scope of practices to win, so we can come with a final decision on how we're going to move forward, because healthcare is evolving. It's 2021. It's evolving. We have telehealth. We have baby boomers getting older. There's a lot of things that's going to come to the table. We have to address healthcare, and we're not going to address it looking down on other professions who can do the job, who has the stats, have already shown that they've done a job exceptional well. No matter what your opinion is, the stats show that they've done a good job this past year. Thank you, Chairman.
Thank you, Representative Cox.
Hey, Doc, I thank you. You know, you're probably, most doctors are very intelligent, and you learn that, I mean, you just, you know, you can do so much stuff, and I don't have any objections with that. But have you ever made a mistake?
Absolutely. I don't think anybody in this room can honestly deny that.
Then that's what I'm saying. You know, and so we have to understand that, you know, we throw out a lot of things about this one made a mistake and that one made a mistake, but I've seen young doctors make mistakes. I've seen older doctors make mistakes. And I've seen great doctors who come in and they're passing by and they go, hey, and you jump in and you do something. And it's amazing what you guys do. And once again, you are the heroes of the day for this whole pandemic. And it still ain't gone yet, in my opinion. So what I'm saying is that we're here talking about trying to put some more people out into areas to go to work. And that's what I'm concerned about. And basically, they've done this for a whole year now without having any implications of any problems. Well, it's been longer than a year. And I hope that would be some indication that, you know, they're doing a great job along with you guys as well. And I'm quite sure nobody will stop talking with each other. Would you not agree with that? I mean, that's why when I go around and people, they follow me around because they're impressed with what you do and they learn from you every time they see you do something. And so every time someone comes to you, that nurse is picking up something that they will be able to go back and replicate because you're that good.
Yeah. It's may I respond to that?
Yeah, I'm done.
I'm not perfect. I am not perfect, but that's why I study, I read, I go to conferences, I go to continuing education classes. Medicine is called practice. There's room for improvement always, and the more education, the better education, the more experience you have, the more colleagues you have to bounce ideas off of. That's what makes me better, and that lessens the chance of a mistake. There's never going to be a perfect practice, ever. And so I am advocating for my patients, advocating for my parents who are getting a little older now, that I want somebody that's at the top of their game, and I want the person that can take care of 99% of the problems well and do the mistakes, the 1%.
Yeah.
That's what I want. And like I said, nurse practitioners and other advanced practice PAs and personnel, they're phenomenal. They have a role. They have a super important role, but it's not the end-all, be-all. The access issue, telehealth is amazing. The new schools are amazing, and that's where we should, it's, the comments about the bread versus steak earlier. It's kind of funny, and it shouldn't be insulting, but I want the best person, not the person that, we think they're good enough. I want the person that is not only good enough, but they're the best at it.
And I understand. And what I'm just saying is there are the best, and there are some that's better, and there's somebody who's struggling, and they may be really good doctors or nurses. So I'm just saying, and that's all I have, Mr. Chairman.
Thank you. Representative Stagney, I'm going to let the other doctors speak, and you have a question, I'm sure, for any of them, if that's good with you. Dr. Brown, would you like to tell us your name and a little bit about you, and go ahead.
Yes, sir. My name's Dr. Kenneth Brown. I'm a family physician in Alexandria and currently president of the LAFP. Mr. Chairman and the esteemed members of the Health and Welfare Committee, thank you for giving me the chance to come and talk today. I had a big old speech, and I think I'm late enough in the day that I'm going to be beating a dead horse with a lot of what I had to say. But, and I've also seen a lot of passion on both sides of this issue today. I do think there can be room for people to work together. I hope to be part of that. I like to consider myself a bridge builder rather than somebody who likes to blow things up. Never been a real big fan of the legislative process, but I can tell you this, I'm really glad I came down here this week. I've had the privilege of meeting several people on this committee in various capacities, from a Trump rally to people here. I hope I didn't just kill myself with the Trump rally thing, but it was a fun, I'm telling you what, it was a fun day. But first of all, I want to say that I am not against nurse practitioners as well as other allied health care practitioners. I've taken part in the training of nurse practitioners. I actually have a Bachelor of Science in Nursing that I got before I went to medical school, so I understand the nursing side of things. And I believe there's definitely an important role for nurse practitioners in Louisiana. However, I would like to see the collaborative agreement continue in some way, shape, or form. I just believe in the value of team play. I didn't always believe in that. I was captain of the ship. It was my way or the highway. I've learned as time goes on, I need members of my team. I need my LPN daily to keep me up to date on what's going on with my patients that they're fielding the phone calls for me. There's definitely a role for everybody. I don't even like to take the position of the captain of the ship anymore. I actually like to be a member of the team. And like I said, I do believe there's a role for collaborative agreements. I think we ought to focus on improving that. I actually had a collaborative agreement in Illinois, which is my home state. So yes, I am a dadgum Yankee, and I'm not leaving. I am down here for good. I didn't realize what I was doing may actually have been above the standard. I did what I thought was right, which was she ran an Amish clinic. My hometown's surrounded by 3,000 Amish. I'm from Arthur, Illinois. And we had regular meetings, at least once a month, sometimes twice a month, where we reviewed charts. We went over cases that she wasn't sure about, and there were times where she called me. I made myself available whenever she called because I knew she was good enough at what she did that she called me where somebody was sick. And I would drive the 2 miles to go to her clinic. And I realize my time is ending here, but I just really think, I'm aware of maybe some substandard collaborative agreements among physicians where they seem to be about taking the money and not doing the work. I think we need to fix that. And I want to maintain high standards of care across the board. I think the residents of Louisiana deserve this. I don't think we need to be trying to pick winners and losers here. I don't think we need to be having a two-tier system. I think the College of Osteopathic Medicine, and right now they haven't graduated the first class, but I think if we can, I think if we can get people out into the rural communities, I think we'll be better off in the long run, end the disparity.
And with that, I will ask Chairman Stagney if he has a question.
Thank you. Thank you, Mr. Chairman. Dr. Brown, I was going to ask you, but I think you answered the question. You do not currently have a collaborative agreement in place. Is that correct?
I have a nurse practitioner in my office, so I guess by default I do have a collaborative agreement.
You have a written agreement?
I haven't signed one. She's actually an employee of our clinic. But we also, the 3 physicians that are in my clinic, we have a working understanding with her, and she will come see us if she has any questions.
Do you charge for that oral agreement?
I'm not aware of it.
Okay. So you don't have what we're all been talking about, a collaborative practice agreement.
Right. She
correct?
Works for us. She's not a partner.
Okay.
But she's an employee of us. So no, we don't have a formal.
Thank you. And I do agree with you that some of those agreements are problematic, very much so. Dr. Labad, you mentioned that an NP can do maybe 65 or 70% of what you can do because you're a physician and you have a bigger, larger, more widely varied scope of practice, correct?
Scope of practice / knowledge base. It's my scope of practice is emergency medicine. It's a defined scope of practice, but my scope of practice is pretty wide compared to some of the other specialties. There's an interventional cardiologist. I mean, they do interventional cardiology. I do variations.
In general, as a physician, your scope of practice is wider than an NP, correct? It's not a trick question.
No, but there's some nuance to it. It's an emergency medicine nurse practitioner does have a wide scope of practice, because the way that I define scope of practice is how many different things am I trained to take care of and I'm comfortable.
You're an emergency medical doc.
Yes, sir.
So you can do surgery?
No, sir, I cannot. Absolutely
not at all.
Nope. I can do some surgical procedures.
Could an NP do any surgical procedures?
No, sir. My understanding is they cannot.
Okay. So the point I was trying to get at, that you said that they did a good job for the 65, 70% of what they do. And they do. Well, I just don't understand. Doc, let me finish. I just don't understand why they would have to pay for the right to do that. And again, we had a speaker speak to us before talking about this is really a debate between no care and APRN care. And as a frontline portal of entry provider, we have serious access problems in this state. And there's no reason why these practitioners shouldn't be on the front line of screening these patients. And if they need to be referring them. They're not practicing outside their scope. They're doing everything they're supposed to do, and then they're saddled with having to pay a fee to practitioners, and I've been on the record, I'll say it again, who rarely review a chart on a daily basis, who rarely look at the drugs that were prescribed. Now, you would think talking to some people, oh, we're going to have these horrible outcomes. Have we? You've seen the studies. I've seen the studies. There's no horrible outcomes. The outcomes are as good or better than some physicians. If this was some sort of epidemic, I would understand it. The education and the public safety part of this, those questions have been answered. Study after study in PubMed, by the way. So I wish we could focus in on the collaborative practice agreements, and if people were reviewing those files and practicing on site, or they would look at patient files on a daily basis or a weekly basis, maybe I would understand it. But they're not even talking about trying to expand their scope. They simply want to take the handcuffs off, and I believe it will increase access throughout this state. And that's what we're talking about. Doc, I appreciate it. Everybody deserves a Mercedes-Benz, right? But some people can only afford a good working Ford. That's all they can afford. And we need to get people health care. And this is a way we can do it. Mathematically impossible to do it in the ways that we've been talking about. The model that has been done for the last 2 decades. It's not working. It won't work. We cannot get enough people seen by enough docs. That's it, Mr. Chairman.
Thank you, Mr. Chairman. Representative Miller.
Can I respond to what he said?
Sir?
Can I respond?
No, you can't ask him a question.
I.
That is the. You asked do you ask him a question? No. All right. You all know that they can't. You want to speak? Well, I'll tell you what I'm going to do. I'm going to close here. I know we've all had enough time to hear. No, we know how we're going to vote. There's no question about that. I've got one last thing, and we're going to vote. We have received one letter in opposition from House Bill 495, and that letter from Dr. Rachel Moore, President of Louisiana Chapter of American Colleges. We received 2 letters of support, House Bill 495 from Sophie Thomas, President of American Association of Nurse Practitioners, and Dr. Mae Wallace, Associate Director of Mary Amelia Center for Women's Health Research and Assistant Professor in the Department of Global Community Health and Behavioral Sciences at Tulane University. We have received 570 emails in support of House Bill 495. 2 have been printed up for the committee, who can watch those if they'd like, or see them if they'd like. I have also, these are red cards that were not read, just like the green cards. Had a great deal of them that did not ask to speak, but they were submitted. And normally we'd read them out, but there's too many. So that leads us to the last thing. I thank y'all for your testimony. If you would go back to your seats, please. I'm going to ask Representative Ivey to come up and close.
See, y'all in trouble. I brought a bottle of water up here. I'm kidding. Members, one moment. Let me get my iPad out so I can read my 3 pages of notes. That wasn't funny? Not in the mood. All right. You know what? I agree with Representative or Chairman Bagley. I think everybody kind of knows where they are on this issue. Oddly enough, this is definitely not the most controversial bill I've ever brought. So, this was not really a hard a challenge for me to bring. I took a lot of notes throughout the testimony, learned a little bit here and there, and in perspective, is certainly one of the things that I started with is very important, and I appreciate the perspectives that our physicians have brought. I also said that be mindful that the possibility that people will try to cloud the facts with issues. This bill is about this document right here. That's what this bill is about. Look, I heard about the educational requirements for our physicians and the training and the hours and that's great, but it has absolutely nothing to do with the bill. The bill is specifically pertaining to this document. Now, oddly enough, I hadn't looked at this document until one of the nurse practitioners had a copy. I saw, and so I went and got a copy. So I want to, my 7th and 8th grade English teacher, she taught me how to break down sentences and, how to understand the meanings and stuff. So if you look at the actual collaborative practice agreement, and this is the template, you can find it on the nursing board's website. I'm going to read the responsibilities of the collaborating physician or dentist. We'll just say physicians. It's 2 sentences. It says to ensure all acts of the prescriptive authority of the APRN are documented and utilized in a manner that is consistent with any rule or regulation imposed upon the APRN's practice, and to be available for consultation, assistance with medical emergencies, or patient referral. Collaborating physicians or dentists must be available physically, by telephone, or direct telecommunication. And that's your collaborative practice agreement. Now, we use the word collaborative practice agreement. The words that a lot of the doctors kept using, supervision, oversight, these words are not found in the collaborative practice agreement. This bill is about requiring an advanced practice registered nurse, who is by law already required, and by the boards and their oversight over their profession, to operate specifically solely within their scope of practice and training and experience. And they have to sign this document. And well, first they have to find a collaborating physician. One of the real issues is, and it was brought up briefly, it's really the independent practice that I think is probably the most concerning. The hanging that shingle, because if an advanced practice registered nurse doesn't hang a shingle, then they're working for a physician or a hospital, and they have all of the supervision and oversight that they were saying is necessary. This document is absolutely unnecessary. One of the best points I heard made, just to reiterate, was the comment regarding the FTC sees this. Look, this has nothing to do with clinical, practice at all. This is a contract, and it's archaic in its nature. So, I want to read in the first part of this document. I'll just read one excerpt. It says, an APRN is educationally prepared to assume responsibility and accountability for health promotion and or maintenance, as well as the assessment, diagnosis, and management of patient problems, which includes the use of prescription and pharmacologic and non-pharmacologic interventions. And so on this document, doctors have been signing, right? They're testing that this is what they do. Am I timed out on closing? Okay, well, you know what? And that's a wrap. Members, I appreciate your attention to this. I think we all agree that we have great needs, and look forward to continuing the conversation on the floor. Thank you.
I think after 5 hours, we probably had enough to decide which way.
Y'all willing to say, Uncle? Let's go.
Yes. Representative Turner has made a motion to report House Bill 495 with amendments. Is there any objection? We have objection. Representative Presley, so we will call roll. Madam Secretary, will you call roll? The vote is, if you vote yes, you vote in favor of House Bill 495. If you vote no, you vote against. Well, thank you for straightening me up. Madam Secretary.
Representative Adams. Representative Carter. No. Representative Cox. Yes. Representative Cruz. Yes. Representative Eccles? No. Representative Emerson? Yes. Representative Hughes? Yes. Representative Johnson? Yes. Representative Laverdane? No. Representative McMahon? Yes. Representative Miller? Yes. Representative Moore?
Before I say yes or no, Mr. Chairman, can I just say 2 or 3 sentences here?
You have not said a word, so I'm going to give you 2 or 3 sentences. Hold up. Let me get you on the mic so everybody can hear you.
I got about 4.5 pages of notes here, and I've been really paying attention to everything that you all have been saying. And it is a difficult situation, it's difficult for me to kind of go either way on here, but I'm trying to follow the data. I'm trying to do the right thing here. I know that what I'm going to say probably won't please, but I'm going to base this decision on what my colleague said. He said that if this bill gets out of here, that we have a speaker that's going to bring people together, and you all going to have to come to some agreement. And I'm going to rely on that. And I'm trying to focus on what this truly is about, what we're trying to do. So, Mr. Speaker, I'm going to go with yes.
Duly noted.
I take that back, Mr. Chairman. I don't want
Duly
to give
noted.
you.
Thank you, Ms. Moore.
Yes.
Representative Moore? Yes. Representative Owen? No. Representative Presley? No. Representative Selders? No. Representative Stagney? Yes. Representative Turner?
Yes.
Yes. I'll tell you your name.
No.
Oh, 10 yeses and 6 noes.
How many yeses? Yeah.
10.
So it does pass. So we'll move forward. Representative Ivey, where'd you go? Oh, okay. Representative Ivey, your bill 495 with amendments will go to the House floor. Thank you.